So good morning and welcome back to the second day of the Philippine Society of Ultrasound in Clinical Medicine Incorporated. So again, we would like to remind everyone that please log in and make your attendance yesterday and today because you will need that for your CPD units. Now, we will be starting the session. We already had our lecture by Dr. Jennifer Kovu. So we will now ask Dr. Edison T. to introduce the next speaker. So Dr. Edison.
Good morning, I'm Dr. Edison T, Pediatric Cardiology. So we have a change in our lecture. So yesterday we heard the lecture of Dr. Jen Kovu on Artificial Intelligence in Fetal Echocardiography. So for this morning, we're going to have Dr. Anthony Chang to give his lecture on Artificial Intelligence in Medical Ultrasound. I would like to properly introduce him now. He's going to give his lecture through recorded lecture. Dr. Anthony Chang attended Johns Hopkins University for his BA in Molecular Biology prior to entering Georgetown University of Medicine for his MD. He then completed his at Children's Hospital National Medical Center and for his Pediatric Cardiology Fellowship at Children's Hospital of Philadelphia. He's a pediatric cardiologist with subspecialty intensive care, where he headed several pediatric intensive care units of different prominent children's hospitals in Boston, LA, Miami, and Texas. He established two medical societies, the Pediatric Cardiac Intensive Care Society, the Asia Pacific Pediatric Cardiac Society. The latter society has its last convention held in Cebu just this February. He is currently the medical director of the Heart Failure Program of Children's Hospital of Orange County. As an author, writer, and researcher, he has written books and scientific articles on pediatric intensive care, heart failure, and artificial intelligence. He is a member of the editorial board of several scientific journals. He also teaches AI in several medical schools.
And the difference between machine learning and statistics is that machine learning can
As a scientist, he introduced the use of milrinone, a valuable cardiovascular drug for severe heart failure, and was part of the team in the development of ventricular assist device in children. Attached to his name, aside from the MD, he has master's degrees in business administration, public health, and biomedical science with focus in AI, and certification in AI from MIT. His present passion is really artificial intelligence in healthcare. Dr. Chang is the founder and medical director of the Medical Intelligence and Innovation Institute, or MI3. This institute is dedicated to implement data science and artificial intelligence in medicine and concomitantly dedicated to facilitate innovation in child health care all over the world. He has started a society for clinicians with special focus on data science and artificial intelligence known as Medical Intelligence Society, or MIS. He is the Dean of the American Board of Artificial Intelligence in Medicine, or ABAIM, that offers education and certification of artificial intelligence to clinical medicine and healthcare as its mission. He is the founder of 3 startup companies in AI in medicine. He is currently the Chief Intelligence and Innovation Officer of Children's Hospital of Orange County. With these brilliant credentials and achievements, let us all welcome our guest speaker, Dr. Anthony Chang.
Hello, my Filipino friends and colleagues. Sorry I can't be there in person with you for this meeting. I'm going to talk about artificial intelligence in clinical medicine and healthcare, and a quick introduction, and then some of the lessons learned and future directions. And hopefully you'll find this information helpful. First of all, I think it's important to understand what is intelligence. We all think we know what intelligence is, but sometimes it's not obvious. I think it's safe to say that it's the ability to take knowledge that you have, not information, knowledge that you have, to adapt to a change in environment. So I think that's really, really important to understand. It's the change in environment that's very key. So I wanted to see, well, what's the impact of artificial intelligence in healthcare ultrasound, which is the title of my talk or subtitle. So I asked an AI tool called ChatGPT that you may be hearing about in the news, and that particular question. So it says improved accuracy and efficiency, early detection of disease, personalized treatment plans, better patient outcomes. Now, it sounds like it's a well-written answer, but what you notice is that it doesn't have the nuances or the depth of the answers. It's pretty much what you get if you asked a medical student or even a college student to research on AI and ultrasound and then give you an answer. So I think it's still going to be a combination of human experts and artificial intelligence. I think that's going to be the best combination. So artificial intelligence can be defined as, and this is my personal definition, so feel free to critique it. It's a computer-enabled capability to perform human-centered science, language, and cognition. And I think it's basically computers doing what humans can do with intelligence. So I was asked to explain some of the differences between artificial intelligence, machine learning, and deep learning. So these are sort of all nested within each other. So artificial intelligence is the broad category that describes not just machine and deep learning, but other techniques as well. It again enables computers to do what humans can do. Machine learning is a subset of the AI techniques that uses statistical methods to, and the difference between machine learning and statistics is that machine learning can improve with data and time. Deep learning, which is getting a lot of popular press, is a subset of machine learning that is has the quality of a multi-layer neural network, or essentially roughly how the brain, one of the ways that brains can work. In terms of timeline, artificial intelligence came in the 1950s, machine learning more in the 80s, and then deep learning really since about 2010. So it's more and more modern methodologies as well. If you look at computer science, data science, mathematics, they're all converging around artificial intelligence and machine and deep learning. So this is a quick diagram to show you how these come together. You can look at AI also as an orchestra of instruments that we have. So machine and deep learning are two of the instruments. Cognitive computing is also one. Natural language processing is becoming very popular, particularly with language models. And then you have other techniques as well. So mostly I'm going to focus on machine and deep learning, as well as a little bit on natural language processing. There's also terminologies like weak or specific AI versus strong and general AI. So right now we have lots of examples of specific or weak AI, like playing the game Go that you probably have heard about in Asia, a driving vehicle that's autonomous, and also classification of skin cancer. These are all very impressive AI feats, but they're still very specific and task-oriented. Versus general AI, which is going to do everything, despite popular contention, ChatGPT is not strong AI or general AI that some of the articles are asking. It is ChatGPT is a language model. It's still a very specific AI geared for languages, although there are ongoing discussions about converging it with images as well as audio files. That still doesn't make it general AI though. The reason why AI has sort of really been very popular as a topic and also substance to as an advanced technology is three things came together. One is the sophistication of algorithms, particularly out of Toronto with Jeff Hinton's group. The second is cloud computing and the capabilities there for store and do many things. And the third is the advance of chips, computer chips, particularly GPUs, thanks to the gaming industry. So all these three things came together and really propelled artificial intelligence forward. And now coupled with big data as well. So perhaps you can say four things. From ultrasound perspective and medical image perspective, we have a type of AI called convolutional neural networks. And this is basically, as you can see from the cartoon here, two separate processes that come together. One is called convolution, one is called pooling. We won't have time to go into the details, but this essentially is a way for computers to see the minute image and then to interpret an image based on other images that it has seen before. So it has a way to learn from the medical images. And in this case, on the right, I'm a cardiologist. This is a cardiac MRI, making the correct diagnosis of dilated cardiomyopathy. By the way, CNN, or convolutional neural network in deep learning, is now able to interpret moving images like ultrasound as well, not just static images like a cardiac MRI or a chest X-ray. So it's a very, very exciting time. We're seeing the very beginning of this period. So thank you, the organizers of the Philippine Society of Ultrasound and Clinical Medicine, for having the insight to know that ultrasound is meeting artificial intelligence in a very big way right now. Another couple of tools in the AI portfolio of tools, one is natural language processing, or how computers and humans can communicate with language. That's very popular now with all the language models, and you'll see more and more, and they'll get more and more sophisticated. Perhaps a less intellectually interesting tool in AI is robotic process automation, which will help clinicians and administrators and technicians to improve their workflow efficiency by having robotic process automation in place. The AI and ultrasound literature, in terms of the publications, has really increased to almost 1,000 articles a year. And that's not counting the ultrasound studies and the different subspecialties. I think this is just general ultrasound. But if you talk about echocardiography, I've done a project in using AI for echocardiograms, or neuroimaging that's dynamic. I think these are all going to be published under the subspecialties, but it's truly a very exponentially increasing sort of interest in artificial intelligence and ultrasound. Now, one of the best things about ultrasound is that it does elevates the clinicians and technicians' clinical performance. So it's going to hopefully raise everyone's level of performance so that we really are better serving our patients and their outcomes. So this is a short video that shows you how technology can improve healthcare. I don't know if this is going to play. I think it was trying to play here. So this is an operating room taking a specimen from the brain in this case and processing it for the pathology lab, but also at the same time putting this sample into the deep learning tool that's in the operating room to basically show the brain surgeons what the sample is showing. So rather than waiting 20 to 30 minutes to get the answer back from the pathology lab, this is now being able to be done in 100 seconds. And with a high degree of accuracy, perhaps this will replace sending the sample to the pathology lab. Notice I didn't say replace the pathologist. The pathologist is still very much needed. Some of a quick sort of overview of the successes and the disappointments in the last 10 years. So if you put in to an AI tool the word cat, this is what you get. So it's pretty good. Success number one, not in any order, is medical imaging, so including ultrasound. So chest X-ray was the first sector that was taken on by artificial intelligence, but since then we have fundus photographs, head MRIs, and as I mentioned earlier, echocardiograms, ultrasound, endoscopy. All of these images are now capable of being interpreted by artificial intelligence. Importantly, in the US, there's now also payment for the use of AI. And you heard about ChatGPT and transformer type of AI tool. There's also merging now of convolutional neural network that I just described with these attention transformers. So it's a very, very exciting time. This is a project that I did with our data scientist, Howard Lai, on using AI for medical images. So this is an echocardiogram with a relatively high degree of accuracy for patent ductus arteriosus. This is, again, a paper that just came out recently, combining the CNN basic image AI tool with the attention, self-attention of transformers. So this is going to be a very exciting development. Success number 2, perhaps, and again, not in any order, is perhaps the use of deep learning for 3-dimensional protein structure prediction. And this is AlphaFold, and it's really narrowed the sequence structure gap. So a lot of exciting drugs, vaccines can be developed from deep learning involved in this kind of work in biomedicine. A third area, perhaps less intellectually stimulating, but it will affect you as technicians in ultrasound as well as clinicians, is the use of robotic process automation or very primitive AI for healthcare administration tasks. This is getting very popular in the United States to use it for not just compliance and reliability and perhaps the business side of medicine, but also quality improvement and safety. So this is particularly exciting with the arrival of large language models like ChatGPT. We're building a community of centers that do AI medicine. Perhaps Philippines can have a representative soon of a center that do a lot of AI in healthcare. The concept of federated learning will make big impact, and I'll show you an example later. But the concept of federated or swarm learning is to be able to work together around institutions without sharing the raw data, just like clinicians and technicians learn from each center, go to another center. So this is very exciting as a technological way around the necessity of sharing raw data. There's also multimodal AI, which means that there are multiple streams of data that can be put together by AI to make sense out of the clinical interpretation and diagnosis. Ultrasound will be for sure one of the planes of information that will be collated for this concept of multimodal artificial intelligence. All right, so disappointments. There have been many, many in the last decade. I'm going back to a decade. So if you put in PDA and echocardiogram, this is what you get. No idea what this organ is. It's definitely not an echocardiogram. So we have a long ways to go. So disappointment number 1 is the lack of access to good healthcare data. Good healthcare data gives you good AI. So we have to really work on this, and potential solution could include this use of synthetic data, as well as federated learning that I just talked about. This is gives you an idea how powerful big data is for healthcare. This is an echocardiogram of a child with Kawasaki disease. So we were wondering, if you have Kawasaki disease and coronary sequelae, what's the implication if you have COVID? So nobody really knew that answer early in the pandemic. And with the help of big data, we're able to answer that question within a few days and was published within a few weeks, I think. So it's very, very impressive how big data and AI can be a really powerful way to answer a question. The second, I think, disappointment is that a lot of studies in AI have not yielded enough clinical relevance or impact. And that's something we have to think about, is the clinical relevance and impact of these studies. The third is that in decision support, AI has been a little bit disappointing. And so this aspect of AI decision support has been disappointing, and it's been public too. I mean, in US newspapers, that AI wasn't as good as we might hope it would be. But sometimes it's a lack of full understanding of what AI is actually doing. And I think another disappointment has been a slow adoption of AI in health systems. But I think it's starting to gain momentum. Another disappointment, it's not surprising that these models, AI models, do not really generalize and cannot just go from one hospital to the next. So on the bright note, let's look at the future of AI in healthcare, so that when you put in patent ductus arteriosus, for those of you who do cardiac imaging, you know this is a PDA, that if you type that into an AI tool to give you a picture, this is exactly what you get. So we have to think about the hype cycles of both AI and emerging technologies to really think about where the future is for healthcare AI. Future direction number one is it would be nice to have a learning system where you in the Philippines can be echoing a patient with heart disease and then can get another cardiologist, if you have questions, from, let's say, United States to work with you, then looking at the same study and interpreting study together. This is what I call a healthcare learning system or nervous system that I think will be the future of how we educate ourselves, how we meet. Instead of going to a conference to learn something new, you will be going to conferences for social and networking and fun things to do, much more than just having all day worth of talks and things that we can learn on our own if we have this community. This is a healthcare learning system in a primitive stage. My colleague and friend, Dr. Wyman Lai, who's a world-renowned echocardiographer for congenital heart disease, is echoing my own daughter for transmission to Rome, Italy, and it's in real time interpreted and visualized by cardiologists in Rome. So it's this kind of connecting of the dots to create a healthcare internet that's going to be very important for the future. Another future direction is the concept of digital twins. So rather than having randomized controlled trials, that's the only way we can gain more information and knowledge. It would be nice to have virtual copies of all the patients, including their ultrasound studies, so that they can be part of a decision to think about different kinds of therapies. So this is really, really important for the future, not just for research, but for just day-to-day therapy of patients. And ultrasound will be a very, very big part of this because it's so readily available. So I see a bright future for ultrasound and AI. The third is something more on the AI side, but to be able to use more cognition for AI. And this means everyone that can think and have creative solutions will be more involved with AI in the near future. So I think this is also very good for AI and ultrasound. So think about AI not as something that can replace you, but something that can help you with your workflow to determine patient records or information to determine whether or not your ultrasound that you're doing is a good enough quality. So those are all AI-enabled processes that will make you a better technician or a better clinician dealing with ultrasound in the future. So, but having said that, if you know nothing about AI or nothing about how AI can help you in your work, then perhaps someone else who does understand that can potentially have an advantage in the situation. So it's good to understand AI in general. So obviously we want human-centered, equitable healthcare, and hopefully AI can help us with that. And I think it's starting from the schools. Some of you probably are recent graduates of schools in ultrasound, and I think everyone really needs to have a basic understanding of AI in healthcare, starting with all the health professional schools and the curriculum. I'm privileged to be teaching AI in 3 medical schools, and it's been a lot of fun for me to show the next generation. So in essence, in order for us to move forward to precision and population health, we need to think about using artificial intelligence to improve the amount of information and knowledge we have so we can take better care of our patients. So it'll be really, really important for that to happen in the future. So this knowledge gap will be hopefully made up by artificial intelligence. There are 4 main areas that I haven't had a chance to talk about. Perhaps if we're in a question situation, I can help answer. The regulatory issues. Here in the US, we have the FDA. Second is the ethical issues to use AI and also ethics of not using AI. The accountability is important, equity and diversity for everyone. And lastly, the legal aspects is still just nascent here in the United States. So I call these the real issues of artificial intelligence. So please, in terms of artificial intelligence, travel far from your home domain to learn from another sector in healthcare or in society in general. Work closely with your AI or data scientist colleagues because they have a lot to offer. And thirdly, welcome everyone to this orchestra that's going to really improve patient care. So technicians, clinicians, data scientists should all work closer together and think of AI as a resource that you can use throughout the hospital, not just for interpreting ultrasound, but how to improve patients showing up with a study. How do you get things approved? How do you register patient data? All of these things can be helped by AI. These are some excellent books and a short documentary that I would highly recommend if you like artificial intelligence. I was the privileged author of a book called Intelligence-Based Medicine, has many of the subspecialties described and how to use AI. Artificial Intelligence and Genius Makers are excellent books. They are very readable. And AlphaGo is a very inspiring documentary on the use of artificial intelligence. And if you're interested in coming to the US, this is an amazing week of activities in June 5th to the 9th, starting with the AI Med Global Summit and to the Stanford meeting that's to follow, and then our Alliance of Centers. I want to thank also the American Board of AI Medicine that supports us to teach courses, 1 and 2 day courses in artificial intelligence. And then we're thinking about bringing a meeting to Asia this year. And I want to thank my many good friends and colleagues at Stanford for always supporting me and our team at home that work on the infrastructure to make everything happen. So with that, perhaps I may or may not be able to answer questions, but perhaps the meeting organizers can forward me the questions and I can answer them back. So thank you for the opportunity and the opportunity to speak to the Philippine Society of Ultrasound and Clinical Medicine. And I hope to see you soon. Bye-bye.
So thank you very much, Dr. Chang, for that very, very innovative lecture. So we would like to call to the stage Dr. Edison T. and Dr. Olympia Malaniaon to moderate the question and answer. And Dr. Jennifer Kovu is in Zoom. Can you put... There you go. Hi, Doctora. Good morning or good evening there.
Can you hear me?
Yes, we can hear
we
you.
can.
There you go.
Hi, Jen. Thanks for coming.
So from the audience, anyone please approach the mic if you have questions for Dr. Kovu about pediatric
Friends, if
cardiology for
you
AI.
remember, Dr. Jennifer Kovu was our speaker yesterday morning. So now you can ask her your question. She talked about artificial intelligence in fetal echocardiography. Hi. So I guess it's afternoon there in a beautiful place of Lake Tahoe. Sorry to disturb your holiday. She's on holiday in Lake Tahoe. Any questions from the floor?
I guess I have a question.
Yes, go ahead.
I'm not a
Obed.
pediatric cardiologist, but I would just like to ask, do you have a database where you submit your echoes so that they can actually collate the data? Because as I understand, for you to have a good artificial intelligence, you have to have a good baseline normal, then pathologic with very good readings. So I think that's one of the most important part that we have to impart. Yes. Can you comment on your data collection on how to arrive at artificial intelligence? Thank you.
So our echocardiogram, all our echocardiograms and MRIs and fetal echocardiograms are stored in a PACS system. So there are different PACS system and reporting system here in the US. What we use is called McKesson, but right now it's a Johnson & Johnson company, but I think there are lots of other systems. I think we're going to either move on to a Philips system called Accelera or Singo. These are reporting systems, but our PACS system, there are two PACS. They're also so they are also all, every time we have an ultrasound, they're stored in as long as we pay for all of these ultrasounds. This way we cannot just only for research purposes get all the data. We could also compare the previous. Let's say I have a patient, a fetal patient with let's say transposition of great arteries with one of the pulmonary arteries getting smaller. Then I can compare the previous fetal echocardiogram based on whatever, like 23 weeks, then at 30 something weeks, if it has changed in size. We currently have a very strong AI program in University of Florida, and I think Dr. Malanya, by asking me to give this lecture, has actually pushed me to start it now for fetal echocardiography. So we do have data, but having said that, I have at least 10 years of data from our current system. It's still not enough. You need a lot of images, not just, and so if you could remember from my presentation yesterday, Arnaut and Anita Moon-Grady have started these fetal echo AI projects at UCSF, but it's not enough. They have to collaborate with my former institution, Boston Children's and Harvard, because they have more data. And even with those two, it's not enough. We have in pediatric cardiology, we're dealing with 1% of, it's a rare, we're dealing with patients that with incidence of 1% out of 100,000 every year. So I think the incidence is so low for, let's say, hypoplastic left heart syndrome. Each institution could possibly get a big program with 30 a year. A small program would be 10 to 15 a year. So if you multiply that by 10 years, that's only how many hypoplastic left heart syndrome patients that are scanned. And so with one center alone, it's not enough. And so the multi-center sharing of AI is really important. And having said that, Dr. Cheng, admittedly didn't touch on the regulatory ethics, and I've touched on yesterday with the patient privacy. It's going to be hard. A lot of people are still wary about sharing data because you cannot totally de-identify them. And the repository of this many thousands and thousands and millions of images takes a lot of money. So I hope in the future, as we are more invested in doing AI, I think somebody will fund this, either the government through NIH grants, which in millions of dollars will not be enough, but more so all these other institutions that are more foundations that are very inclined to fund medical researches, like the Zuckerberg funding, these in Silicon Valley funding, and others. So I think the future is really, really good. The future is really bright, and I think it's just, we don't need to be afraid. I think for me, AI will optimize mine and my sonographer's workflow. And if they can if AI can deal with the mundane, let's say for fetal echocardiography, the mundane tasks would be the measurement of the head circumference, measurement of the abdominal circumference, which sometimes it's so hard, and a lot of sonographers will try to spend a lot of time taking those measurements and spend less time in trying to figure out what the heart disease is, because they only have, like, let's say the clinic visit is an hour. So I think if we can streamline all those, the head circumference by the biometrics, I think the sonographer and the doctor will have more time to figure out what the anatomy with the anatomy of the congenital heart diseases.
Jen, I have a follow-up in relation to the question of Dr. Obet-Chan. So, a lot of hospitals or X-ray department, they have the PAC system or etc. So, are these being used eventually to build up AI in the different companies? Are we contributing already to this? Because AI is from data we fed to them, right? So, are these PAC system, they are collated data every day we do the ultrasound. We're gathering this data in the PAC system. Then this PAC system, suppose that they should stay in the institution, but are they being sent to the ultrasound company for them to further develop all these new technologies advancement? Jen, please unmute yourself.
Can we try it again, Jen? Try and
Can you hear me?
oh
Yes,
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 that's
yes.
good. You're back.
All right, excellent.
Dr. Chang is here also.
Good morning or good evening,
Hi,
Dr.
Dr.
Chang.
Chang, good morning.
Thank you very much
I
for coming in.
You're
I
able to
just
make
got
it.
home, so I'm glad I can join you just in time, I hope.
Thanks, thanks.
Thank you, thank you.
Yes, Jen, you were about to say something. Oh, we lost you again, Jen.
Dr. Chang, we have a question to Dr. Jen Govo. It's about the PAC system, the etc. So we ultrasonographers are doing all these procedures. We enter a lot of this data into the PAC system or etc. Are we contributing to the AI? Do this data goes to the ultrasound machine to improve the AI of the company?
Yeah, what I'm trying to build is a way for, first of all, end-to-end continuity of ultrasound with AI so that you can actually see if the picture is good enough for interpretation. But also, I think we have a way now using edge computing to make sure that the images can be transmitted to anywhere else around the world simultaneously. So for interpretation. So I think there are many encouraging advances. As I talk, did you already play my talk? I assume you did, right?
Yes, yes, you heard your talk already. Yeah.
Okay, so one way you can, I was very frustrated. I was doing a consultation on a child in Myanmar and I was not able to get images from the US. So I wanted to solve that problem. So once you solve that problem, then you can use interpretation AI to look at images, including complex ones like congenital heart disease on echocardiogram. And then the model will learn from the echo and then get smarter and smarter. So that's the nice thing about AI. Eventually, it'll be the smartest cardiologist on the planet because it's seen so many millions of echocardiograms. So that's, I think, very, very exciting for the future of ultrasound. So the saying is not ultrasound will replace, technicians, is that technicians who understand AI will replace technicians who do not understand AI, just because I think the world is changing very fast, so, but it's a great future.
Jen, yes, you
Can you
would
hear
you
me
like
now?
to? Yes, yes, that's great.
All right, excellent. So I think I echo Dr. Chang's sentiment. I think, and then your question as to are they already storing the images right now? I don't think they can unless you are in an agreement with the company that they would be using. They would be using whatever you submit to them for research purposes. I think they cannot. But I think more and more research bound companies are going to try to do that. As to there are other softwares though that have been in agreements with a lot of institutions. So let's say an MRI. There's recent software where every time you try to draw circles into their system, they would try to use that to make sure to improve the drawing of the circles in the ventricles, to measure the ventricles. So they would try to use that to make the drawing of the circles, automated drawing of the circles, better. But again, you have to legally, your institution has to be in a legal binding cooperation with them, or like if there's a contract. They cannot just use it, and they cannot just use patient data without a contract or without a data use agreement.
Okay. So we would like to beg the indulgence of the audience because it's very rare that we have these two experts to talk to. So we will be asking more questions, okay? So Doctor.
Yes, Dr. Dizon from Nueva Ecija has a question. She's a pediatric cardiologist.
Oh, hi.
Good morning. Good afternoon, Dr. Kovu, Dr. Chang.
Hi.
Thank you for the lectures. Again, they're really learning experience for us, because years ago AI is just an imagination, right? For especially in medicine, and now it's becoming more real, especially in our practice. So this is a concern in the future. Probably, are we now trying to establish a regulatory or ethics committee for this? Because especially in the future, when AI is already an established partner in our practice, so in cases, my concern is that in cases that we have, there's a conflict between the AI input and the physician's feedback. So so that's my concern. So are we now trying to establish a regulatory or ethics committee for that, so that in the future, I hope there will be less problem arising from these concerns?
Yes, who wants to go first? Well,
I will let Dr. Chang. I just want to full disclosure. I am not an AI expert. I'm a fetal cardiologist and pediatric cardiologist, and
Okay.
Dr. Chang is the AI expert.
Well, I'm still always a student, but no, you pose a really interesting question. So let me ask you this: what do you do when two colleagues are disagreeing? Human colleagues are disagreeing. You try to find a reconciliation somehow, right? So I think AI can be looked upon without anthropomorphizing the AI as a colleague, that may have seen more echoes than you have, and perhaps even more accurate a diagnostician than you, and try to resolve it with the AI, rather than this unhealthy, I think, human versus machine contest almost that I see in some papers. So I think please consider AI as a very smart, intelligent partner that's trying to make your life easier rather than to make your life more difficult by having disagreements with it. It's going to have advantages and disadvantages. Advantages is that it's probably going to be more consistent and more accurate than you are, or even than a group of cardiologists. The disadvantage is that it's not going to be probably very good at really unusual cases or outlier cases. So it hasn't probably learned from everything, but it's going to get smarter and smarter. Within a decade, I think it would be hard to argue that any AI tool is not going to be consistently better and more accurate than human cardiologists. Doesn't mean that you should stop reading echoes. It just means that your life will be easier because you're basically working with the AI to be faster and better and cheaper also, because your time can be better spent talking to your patients rather than looking at each frame, trying to figure out what's going on. And you'll be just like very few of us carry calipers any longer measuring QT intervals. Like I was tortured with when I was a fellow, because if you think about it, is it really contributing to patient care? No, it's not. So it's all automatically done now. So we'll get to that point with echocardiograms, plus learning things from the AI. And I think sometimes we don't emphasize that. Right now, in certain health centers, they can almost tell you exactly who the patient is by looking at their echocardiogram. So there are a lot of intrinsically distinguishing features of patients that we probably don't appreciate as much as the AI can. So the AI can tell you if you're going to be at risk for having diabetes by looking at either your 12-lead electrocardiogram or your echocardiogram. So that's very useful information to follow patients. So I think we should remain perhaps a little bit humble as humans and learn from our AI partners to become better cardiologists.
Yes,
I
you have a question of it. Oh, yes, follow-up
I'd just like
question,
to thank
Doctor.
you, Dr. Chang, for that input. So we are looking forward to that future.
Okay,
Thank
by
you.
the way, I think I mentioned during the talk, I learned a lot by my fellow co-authors writing 52 chapters on different topics of AI in medicine. So and cardiology. So I think the future is really bright for ultrasound. The future is really bright for cardiology to be able to deploy AI intelligently in the various aspects of ultrasound. So I think it's a really, really exciting future for ultrasound.
Thank you. You have a question of it?
Yes, this is Dr. Robert Chan, orthopedic. I am the perfect example of AI. My intelligence is artificial. However, I really believe that for ultrasound, it's the man behind the gun. But we also have to take into consideration the gun. So I think the problem with some of the third world is that the quality of the ultrasound in some areas are not as good as the big hospitals because they can afford so much. But there are some cases in the third world that are more common, like TB in the cardiac and everything. So that it's so sad that whenever they get these images, the vision, the quality is not so good. So how can we probably address that? And if it will become an international collaboration, I think that would really help everyone because we all know that there are certain localities that have more cases for certain disease entities, so they can be experts for this. So how can we resolve that?
Jennifer, did you want to try to answer that first? And I'll follow you.
um so I think uh what you are asking is how can we resolve if there are certain
We lost you, Jen. Again, the sound.
I think the
can you
speaker
hear
or
me?
the mic.
Go ahead.
Can you
Go
hear?
ahead. Yes.
Yeah, can you hear me? All right. So I think, can you hear me?
Yes.
Yes, Lake Tahoe is have a choppy
Sure.
internet. Yes.
Yeah, there was a blizzard here. So, anyways, so I think there are a lot of, and that's what from part of my talk, there were a lot of studies that are trying to improve those, even the ultrasounds that have bad resolutions, that they've developed AI to improve those, like try to predict what they were trying to show. So I think with that, and it started with X-rays, and now with moving ultrasounds, I think they have tried to mimic it with, especially with the CNNs, and they tried to do, and they've proven it with ground truth. So there are they did different variations of, let's say, a single patient with real world scenarios of bad windows in ultrasound. There's a shadow in from bone, let's say in fetal ultrasound. So what they did is they tried to AI tries to remove those artifacts, and still the accuracy is really good in predicting what the patient's disease is. So I think with this, again, is another advantage of AI. It won't replace any one of us humans. It would just improve, especially it would improve ultrasound quality, especially with places where the ultrasound machine is not that updated. So I think it's good.
Dr. Chan.
Yeah, I think Jennifer answered that quite well. I think in addition to the workflow being sort of embedded with AI, so that you get the images, much better in the first place, and without intimidating the technicians in the audience there, the need for a seasoned technician is probably going to be less and less because the AI will be good enough to guide the younger technicians to do a completely good study. So I think that's one thing. The other thing is, as Jennifer was saying, all these data augmentation techniques and CNNs that can really, it's like how, a computer knows the word that you're trying to type before you finish typing the word. It's the same concept with images. If you can imagine that, it's like an autocomplete. So you don't really even have to have all the images perfect. You don't have to even have probably the whole series of images to be able to make a diagnosis. It's going to save time. It's going to save the inconvenience. And I see in the very near future in some countries where, and you'll have to wait and see if this fantasy comes true, that you actually don't even have to go to a clinic or a hospital. An ultrasound probe will be shipped to you at home. You get on your iPhone and you take pictures of your heart, you take pictures of your abdomen, and you send the image in because it's already validated with AI. So in terms of peripheral AI, so they already have microprocessors embedded with very primitive AI. So it's just a matter of time before we have ultrasound probes that actually have AI embedded in it so you can actually get the best pictures. So what we call a smart transducer.
That's good. We want this to go on really. We treasure your presence here, but we have to move on with the rest of the meeting. So in behalf, I have plenty of questions, so I'll just email them to you. So in behalf of the whole organization and all the participants here, we would like to thank you very, very much for taking this time to share with us the latest in artificial intelligence. So let's give them a big round of applause. Thank you very much.
Thank you, everyone.
Thank you, thank you, thank you,
Hope to
Dr.
see you soon.
Jennifer
Bye,
Chang.
Jennifer. Okay.
Thank you very
Bye.
much,
Thank you.
Jen
Bye bye.
and
Bye bye.
Dr. Chang.
Thank you
Bye-bye.
very much. So thank
Good
you
morning.
again to our esteemed speaker for taking the time with us. We will treasure this. So we will now move on to the next part of the lecture. We would like to call on Dr. Mario Benito Bautista to moderate the next session.
Good morning, doctors, ladies and gentlemen. Thank you very much, PSUCMI, for requesting me for this honor to moderate this
Session. So for our first session, the topic's title is Introduction to Deep Infiltrating Endometriosis for the General Sonologist. It's my honor to introduce as an expert who's not new to the PSUCMI, Dr. Vigildo Boycomia. He's a very well-respected OBGYN sonologist in the Philippine General Hospital. He requests that this curriculum meeting be short. So as I know, he's a medical specialist 3 at the Philippine General Hospital. He's the former head of OBGYN ultrasound at the St. Luke's BGC. And he's a teacher at the University of the Philippines College of Medicine, Department of Obstetrics and Gynecology. Dr. Kumia is not new to the PSUCMI, no? He was also our lecturer in 2019 at the Joint Convention of the USP, where he lectured on pelvic tuberculosis. So for today, we will listen to his expertise on deep infiltrating endometriosis for the general sonologist. Boy?
My talk will cover the following: the definition of endometriosis and DIE, pathogenesis, classification, and then the dynamic ultrasonography for DIE. Endometriosis is a complex and chronic estrogen-dependent condition characterized by the ectopic implantation of functional tissue lining the uterus outside of the uterine cavity, and with consequent chronic inflammatory reaction and fibromuscular hyperplasia in pelvic peritoneum, the pelvic wall and organs. The diagnosis is quite often delayed because of non-specific manifestations. Endometriosis causes symptoms such as severe pelvic pain, dysfunction of the organs of the pelvic cavity, and infertility. It affects about 5 to 10% of girls and women of reproductive age. The peak age of patients is between 25 and 45 years. 20 to 50% of infertile women and nearly 90% of infertile women with chronic pain. The disease can be found in practically all sites throughout the pelvis. It can also be found in other areas outside the pelvic cavity, like in the gastrointestinal tract, less often the pleura, pericardium, or the CNS. There are several different pathogenic pathways that have been considered to explain why and how it is able to spread to so many areas of the body. But the true pathogenesis of endometriosis remains poorly understood. No single theory can fully explain the many varying presentations of endometriosis. Some authors even propose the combination of these theories to help explain those gaps. The knowledge of exact mechanism of the origin and progression of this disease is significant for the appropriate treatment. Diagnostic laparoscopy is considered the gold standard for the diagnosis of endometriosis, but it is invasive with possible false negative results. Nowadays, there is a paradigm shift from surgical to non-invasive diagnosis based on symptoms, response to therapy, and imaging. Now, correct site-specific diagnosis is fundamental in defining the optimal treatment strategy for endometriosis. Non-invasive imaging methods are required to map accurately the location and extent of endometriotic lesions. Ultrasound and MRI are the key imaging modalities in correctly identifying and localizing endometriosis. Transvaginal ultrasound is the first line of imaging technique in the diagnosis of pelvic endometriosis and define the extent of disease, in particular for deep infiltrating endometriosis or DIE, owing to its wide availability and comparable accuracy to MRI. The specialized ultrasound techniques are used for the detection of DIE, where evaluation is extended beyond the uterus and ovaries to assess the anterior and posterior pelvic compartments, and it includes a dynamic assessment of organ mobility and site-specific tenderness. Prediction of severe forms of DIE as well as the pouch of Douglas obliteration during transvaginal ultrasound is helpful in planning a multidisciplinary surgical approach. The main classification of endometriosis is based on localization and histopathology. There are 3 subtypes: superficial peritoneal endometriosis, ovarian endometriosis, endometriotic cyst, and deep infiltrating endometriosis. The superficial peritoneal endometriosis rarely causes severe clinical symptoms. It is found on the surface of organs of the pelvic cavity and often only attaches to the peritoneum. Ovarian endometriotic cysts appear on the ovaries and form cystic structures known as the endometriomas or chocolate cysts. These cysts are filled with hypoechoic fluid and vary in size. This subtype is associated with infertility and ovarian cancer. DIE can invade visceral organs to a depth of 5 millimeters or more, within or outside the pelvic cavity and distort local anatomy. It causes significant symptoms, so it requires surgical treatment frequently. There is local inflammation and consequently to fibrosis and muscular hyperplasia. The lack of gold standard staging system is a concerning issue in the treatment of endometriosis. A reproducible and well-organized classification system is necessary, not only to clarify communication among physicians, but also to standardize the optimal treatment strategy. The ideal staging or classification system should be able to explain the extent of the disease, predict pain or fertility, provide accurate information to the patients, and reflect the anatomical features. There are at least 4 standard surgical classification systems, namely the Revised American Society for Reproductive Medicine or ASRM classification, the Ancient classification, the Endometriosis Fertility Index, and the AGL or American Association of Gynecological Laparoscopy classification. Of these, the Revised American Society for Reproductive Medicine classification is the most well known. It is mainly a surgical staging classification tool. They define the stage classification as minimal, mild, moderate, and severe, and each is scored. Endometriotic nodules and adhesions are mapped and scored, taking account the following: the size of the nodules, the depth, cul-de-sac obliteration, location and density of adhesions, and laterality. AAGL grading is developed for scoring intraoperative surgical complexity and to examine its correlation with patient-reported pain and infertility. This is more detailed than the ASRM classification because it includes the more distant locations. In this multi-center study, they prospectively compared AAGL versus ASRM and compared against the 4-level surgical complexity scale defined by the most complex procedure performed. The results showed that the AAGL classification can reliably discriminate surgical complexity levels better than the ASRM staging system. But both the AAGL and the ASRM severity stage can correlate with the pain and infertility symptoms. Currently, none of the classification systems are considered the gold standard. Here's another surgery-based classification. The Endometriosis Fertility Index was developed to predict the fertility outcomes in patients who underwent surgery for endometriosis. Now, here is the Ancient classification, which is an improvement of the ASRM classification. It was developed to classify DIE in the retroperitoneal structures. The Ancient score, like the ASRM, is determined by the extent of endometriosis during surgery. In 2016, the International Deep Endometriosis Analysis, or IDEA, group published a consensus opinion on the terms, definitions, and measurements that may be used to describe the sonographic features of the different phenotypes of endometriosis. The standard terms must be used in the standard sonographic measurement, and the descriptions of the ultrasound lesion and the extent of endometriosis. This will allow the meaningful comparisons in future studies of endometriosis and should facilitate multi-center research for endometriosis. Now, the ultrasound-based endometriosis staging systems were thus developed and further validated. Recent studies even used ultrasound to predict the level of surgical complexity. In this multi-center prospective and cohort study, the accuracy, sensitivity, specificity of UBES, or ultrasound-based endometriosis staging system, for predicting a requirement for the for the 3 levels of laparoscopic surgery were high. So this can help triage the most appropriate surgical expertise required for laparoscopic endometriosis surgery. In this prospective multi-center diagnostic accuracy study, TBS and TAS are used using the Ancient classification system. and there was about 86 to 99% concordance with the surgical ancient staging. Now, using the previously mentioned staging system to identify the different phenotypes of endometriosis, it requires a thorough and dynamic ultrasound. Dynamic ultrasound for DIE is an extended and detailed scan, focusing on finding foci endometriosis in the pelvic cavity and can explain the cause of pelvic pain and infertility. I will use IDEA because this is what I've been using since 2017 for examining the women with clinical suspicion of DIE or non-endometriosis. All these steps should be performed, but not necessarily in this order. So, the step one is just doing a routine transvaginal ultrasound for the evaluation of the uterus and ovary and the next day. Specific attention should be paid to the presence of adenomyosis or ovarian endometrioma. An uninverted or retroflex uterus has a strong association with adhesion and the posterior compartment. Typical sonographic features of adenomyosis are noted, like asymmetric thickening of the meningium, usually the posterior meningium, the presence of posterior acoustic shadows in a funnel-like pattern, small echogenic cysts scattered in the meningium. Color mapping shows short scattered vessels within the meningium. This may have associated adenomyoma, which are myomas with poorly defined borders. Then you look for the presence or absence of endometriomas. You take note of the size, number, ultrasound appearance of ground glass appearance, and measure them systematically in 3 orthogonal planes. The sonographic characteristics of any endometrioma should be described using the IOTA terminology. Normal ovarian rim with antral follicle should be noted too. The kissing ovary sign means 2 ovaries of endometriomas are fixed to each other. Color Doppler helps to identify the residualization of endometrioma in pregnancy with the increased vascularity and population and may mimic malignancy. These should regress after per period. In step 2, we evaluate for sonographic soft markers like the site-specific tenderness and ovarian mobility. By applying gentle pressure using the transducer, while the free hand is alternately pressing on the pelvic area, the ovaries can be seen to move in real time. If mobility is reduced or not present, this can mean adhesions. You take note also of the tender sites, as this may indicate superficial disease or DIE. In step 3, we evaluate the status of the pouch of Douglas using the real-time based sliding sign. We can assess the sliding sign even when the uterus is anteverted and retroverted, just like an internal examination. We just do the gentle pressure against the cervix using the probe and see that the anterior rectal wall glides freely across the posterior vaginal wall, the retrocervical region, and the posterior aspect of the uterine serosa. So this is a positive sliding sign. Here, the probe is placed on the posterior fornix. In negative sliding sign, there is no or limited gliding motion in the cul-de-sac. In step 4, the assessment for DI nodules in the anterior and posterior compartments. Here are the different morphological types of bowel DIE. Sonographically, bowel lesions are hypoechoic and rigid, and they have retraction and adhesions. The sliding sign is expected to be negative. The combination can occur and denotes more severe form. IDEA proposes dividing the bladder ultrasound assessment into 4 zones. The trigonal zone, which lies within 3 centimeters of the urethral orifices, the bladder base or the vesical uterine region, which lies adjacent to both the vagina and the cervix. And 3, the bladder dome, which is the intra-abdominal portion covered by peritoneum, and the extra-abdominal bladder, which is the anterior retroperitoneal area below the pubic bone. Here are example nodules in the urinary bladder fundus or base, and the uterovesical region and ureter. If the bladder does not slide freely over the anterior uterine wall, then the sliding sign is negative, and the uterovesical region is classified as obliterated. The previous cesarean sections can also have the adhesions and elicit negative sliding sign, and these are not necessarily a sign of the pelvic endometriosis. The course of the ureter should be traced from the trigon of the bladder as the intravesical segment of the ureter courses to the pelvic side wall and up to the level of the common iliac vessels. Peristalsis confirms ureteric patency. The point of compression or suture by DI should be identified. The distance of the distal from the ureteric offices to the stricture should be measured. The degree of hydronephrosis should be assessed to and graded using generally accepted ultrasound criteria. In the posterior compartment, the most sites of DIE in the posterior compartments are the uterosacral ligaments, posterior vaginal fornix, the anterior rectum, rectosigmoid junction, and the sigmoid colon. On TBS, the posterior compartment lesions appear as hypoechoic thickening nodules or solid nodules on the wall of the bowel surface or vagina, which may vary in size and have smooth or irregular contours. DIE lesions below the level of the insertion of the uterosacral ligaments and surface is denoted as the lower anterior rectal DIE lesions. Those above this level is denoted as the upper anterior rectal DIE lesions. Those that are at the level of the uterine fundus are the rectosigmoid junction DIE lesions. Those above the uterine fundus are anterior sigmoid DIE lesions. The distance between the lower margin of the lesion and the anal verge should be measured using the TBS. Here's how the rectovaginal septum is defined. The rectovaginal septum is below the blue line, passing along the lower border of the posterior lip of the cervix. The posterior vaginal fornix is the red line at the caudal end of the peritoneum or the cul-de-sac. The upper limits of the RVS is the blue line at the lower border of the posterior lips of the cervix. Here is the example of the RVS-DIE. Isolated RVS-DIE is rare. RVS is usually an extension of posterior vaginal wall DIE, and the use of gel sonovaginography improves the detection of posterior vaginal and RVS-DIE. Anterior rectal DIE and intact vaginal wall and RVS is noted as the hypoechoic lesion in the rectovaginal septum. The involvement may be both in the posterior vaginal wall and anterior rectal wall. The low RVS lesions, when managed surgically, are associated with severe complications, including fistula. Posterior vaginal fornix or forniceal endometriosis is suspected if the posterior vaginal fornix is thickened or if a discrete nodule is found in the hypoechoic layer of the vaginal wall. The hypoechoic nodule may be homogeneous, inhomogeneous, or maybe with large cystic spaces, or they may not have cystic spaces surrounding the nodule. hourglass-shaped or diabola-like nodules occur when DIE lesions in the posterior vaginal wall extend into the anterior rectal wall. Bowel DIE classically involves the anterior rectum, rectosigmoid junction, and or sigmoid colon, all of which can be visualized using the TBS. Bowel DIE can be isolated, multicentric, or multifocal. The uterocycle ligaments is hyper-echoic elongated structure oriented transversely and obliquely. It is seen at the posterior aspect of the lower uterine segment, at the level of the junction of the cervix and corpus. And at the midline, it is called the torus uterinus. Thickened USLDAE can be measured in the transverse plane more easily. Nodules may not be tender to pressure. Here, the DI lesion is located at the torus uterinus, which is located at the center posterior to the cervix. The level of cul-de-sac obliteration can be at the retrocervical level, mid-posterior uterus, or the posterior uterine fundus. Here are the other areas of DIE outside the pelvic cavity, like in the abdominal pericardium, umbilicus, umbilical area in the CS card. Here are another atypical sites, and these atypical sites are suspected as DIE because of the cyclic pain associated and sometimes with bleeding. So, in summary, no single theory can fully explain the many varied presentations of endometriosis. Ultrasound is the first line of investigation tool in the workup of women with potential underlying endometriosis, and the ability for ultrasound to detect ovarian endometriosis and DIE is well documented. The prediction of severe forms of DIE as well as cul-de-sac obliteration using transvaginal ultrasound is helpful in the planning and multidisciplinary surgical approach. With the exception of DIE affecting the rectovaginal septum, transvaginal ultrasound is in the hands of the well-trained staff is a highly accurate and reproducible method for non-invasive diagnosis of DIE. Currently, none of the classification systems are considered the gold standard. The systematic approach is needed in examining the pelvis in women who suspected endometriosis and define terms and measurements to describe the appearance of endometriosis on a sonography should be used. Standardization of terminology should allow meaningful comparisons between future studies in women with an ultrasound diagnosis of endometriosis and should facilitate multi-center studies. Thank you.
How much additional time do you allot for to the routine gynecologic transvaginal? How much additional time would you allot for the additional findings at the DIE? Is this a pre-programmed additional time, or is it dependent on your findings on the initial transvaginal?
Yeah. Referrals for DIE that I received are mainly because of pelvic pain. So sometimes patient will come to me with pelvic pain, and then when I do ultrasound and do all the four steps I mentioned, and found out that there's no signs of DIE or endometriosis, it won't really take too long. Additional time to the regular scan is about 5 to 10 minutes. But the more lesions that you see at least 15 minutes more, 10 to 15 more than the usual scan.
Dr. Pumia, what is the differential diagnosis when the patient is sent in for pelvic pain? What makes you make a differentiation between endometriosis and the other possible diagnosis that can cause pelvic pain?
Important in the assessment of DI or endometriosis is the thorough history, especially the surgical history, because adhesions and possibility of malignancy should be thought always. But the guidance that I follow is rule out malignancy first before I entertain DIE, and so I add color mapping, because the more vascular hypoechoic lesions I lean more to look for a possible malignancy.
So would you say that endometriosis, what is the usual color pattern for an
DIE should
endometriosis?
be avascular. Most of the DIC, especially those who have been treated with progestins and other hormones, are usually avascular as they are being treated.
How about the differential diagnosis of sequela of infection, pelvic infections?
Yeah, that's difficult. You have to correlate clinically and correlate with the laboratories to really support the possibility of infection.
Doctor, if we see adenomyosis or endometrioma, are we obliged to see everything like the uterus sacrum?
I think that should be the rule now, since we are more aware actually of the presence of DIE. The moment the patient complains of pelvic pain or dysmenorrhea, the evaluation for the presence of DIE should be completed, especially if there are already adenomyosis or endometriosis. Even if it is not included in the request of the referring physician, I tend to complete the DIE, and this will give a more holistic interpretation of the extent of the endometriosis, especially if you're going to decide on doing the surgery.
Are there any other questions?
In relation to our field, is the DIE, is AI applicable to DIE? Because we will be monitoring the patient. Siguro in the span of 1 year.
Yes, once the patient's label is DIE, the subsequent monitoring is always, especially if you're already treating it, so you still continue to monitor the size and the progression of more lesions and the subsequent follow-ups.
So how would you, when you do the ultrasound report, your recommendations, would you give a range of time or time frame when another scan would be recommended?
2 to 3 months, within 2 to 3 months, especially because once you give the diagnosis, the patient will be being treated. So significant change because of your management will be seen in 3 to 4 months. DIE is a slowly responding lesions. Sometimes after 3 months, they're still the same size. Also, so the thrust is to looking for more additional lesions. If the treatment is inadequate, you suspect more lesions, more new lesions, or progression of the endometriomal size if surgery was not done.
So you mean to say that in your observation, deep infiltrating endometriosis regresses more slowly than, let's say, endometrial cysts under medical treatment?
Yes, very. So the appearance of the nodules that identified before will actually just change in the quality. It's less hypoechoic when you're giving a treatment, medical treatment. So it's not the size, but more of it will become more hyperechoic because of the subsequent fibrosis.
Okay, so I think, one last question.
In terms of the technical approach to the IE, so it would really, for the general sonologist, it couldn't be an abdominal probe. It should be an endometrial.
I usually do the transvaginal first and then supplement it with abdominal, because as I said earlier, there may be other sites outside of the pelvic cavity. So especially, and I said earlier, that part of the DI evaluation is an evaluation also of the kidney, especially if you see that there are more extensive sites of DI identified. So you look at the kidneys also to assess the secondary involvement.
Okay, thank you for your questions. We'll proceed to the next lecture of Dr. Precious Diaz.
Good morning. Sorry for the delay. Thank you, Dr. Martin, for the introduction. Thank you also to PSUCMI for inviting me here. And congratulations on your 25th anniversary celebration. So I was given the task. I did 3 here on the cycle. No problem with the coordinate compatibility, but I'm just here on this. So this morning I am given the task to update everyone. Actually, this is more of a review for some on the guidelines in performing first trimester ultrasound. So my lecture will follow this outline. To start with definition and enumerate indications of first trimester ultrasound, illustrate normal ultrasound appearance of first trimester scan, and discuss abnormal sonographic findings in terms of viability. Then we proceed with the guidelines in performing first trimester scan in the late in prenatal diagnosis and aneuploidy screening. First trimester is defined as the period between conception and 12 weeks after. This is divided into the early first trimester and late first trimester. Some experts would call it the embryonic phase and fetal phase respectively. Indications vary depending on the timing of the procedure. Generally, the early first trimester ultrasound is done for pregnancy dating, for establishment of viability and a certain pregnancy location, while the late first trimester scan can provide us more information in terms of fetal anatomy, allowing us to identify major structural anomalies and perform a first trimester risk assessment for aneuploidies. So a first trimester ultrasound procedure would require the following at the minimum. in the first trimester, ultrasound is considered a safe procedure as long as one will follow the following precautions. We should employ the lowest possible ultrasonic exposure settings. We follow the ALARA principle. The thermal indices should be limited to less than 1, and we use the M mode in documenting heart rate. Unless we are for evaluation for anomalies, we use the spectral Doppler. So the role of ultrasound actually becomes very apparent as early as 3 weeks from conception, and the progression of sonographic findings in early first trimester follows a predictable pattern. The first sonographic feature is the gestational sac, which appears at 4.5 to 5 weeks gestation. Then by 5.5 weeks, the yolk sac appears. This is the first anatomic structure, seen in the gestational sac. By 6 weeks, you will see a 1 to 2 millimeter echogenic structure emerging from the yolk sac, which represents the embryo. This is measured as the crown rump length. So how do we measure the gestational sac? It is measured as the mean of 3 orthogonal planes, known as the mean sac diameter. Similar to the gestational sac, the yolk sac is measured by placing the calipers in the inner wall, calculated as the average of 3 orthogonal diameters. The crown rump length is ideally measured in mid-sagittal plane of the whole fetus, in neutral position, perpendicular to ultrasound beam. Early first trimester is an effective tool in establishing pregnancy dating. So here is a table showing a guideline in reassigning due date based on ultrasound scan when you are unsure of the LMP. For example, in pregnancy less than 9 weeks gestation, we compare the due date of the LMP with the due date of the ultrasound, and if the difference between these two is within 5 days, we follow the due date of the LMP. If the difference is more than 5 days, we reassign the ultrasound as the due date of the said pregnancy. In pregnancy between 9 to 14 weeks, the threshold for reassignment becomes 7 days. Fetal heart activity can be detected as early as 5.5 weeks. It is almost always appreciated at the crown rump length of 4 to 5 millimeters, which is equivalent to 6 weeks gestation. This weight changes to 100-215 at 6 weeks, becoming 145 to 159 at 8 weeks. It peaks at 9 weeks and will slightly decline at 10 weeks. Here are some sonographic images highlighting the milestones in the developing embryo. At 7 weeks, you can actually visualize the amnion here. You can distinguish the head and the body segments. In this image, you can see the yolk sac. So as early as 8 weeks, you can see bowel loops protrude into the umbilical cord, and this is illustrated in the image. This is a normal phenomenon called the physiologic mid-gut herniation, and this eventually returns in the abdominal cavity at 11 to 12 weeks. In the same image, one can also appreciate the following structures: the yolk sac, the amnion, the cord insertion, the urinary bladder, and the posterior fossa of the brain. In this video, you can also see many structures. This is a transvaginal scan to the grayscale of a 10-week fetus. This is the yolk sac, you can see that, and this is the brain structures. You can see the choroid plexus there and the lateral ventricles. I'll play. So you can also see the mid-gut herniation here, which is near the umbilical cord insertion. and the genital tubercle at the rump. Doon po. So here is a table summarizing the timing of sonographic appearance of major embryonic structures. So as you can see, at 7 weeks, you can appreciate the single ventricle already. And at 9 weeks, you can visualize brain structures, which include your facts, your choroid plexus. You can also see the movements of the upper and the lower limbs. At 10 weeks, you can start to appreciate the buccal translucency. Then you can see both kidneys at 11 weeks, and at 12 weeks, you can appreciate the four-chambered of the heart. When one becomes familiar with the sonographic features of embryonic development, one will be able to assess the viability of pregnancy with certainty. So this is the box CPG on obstetric ultrasound, listing the following definitive sonographic findings of a failed intrauterine pregnancy. So if on initial ultrasound, you are able to see a crown rump length of 7 millimeter or more, and still without cardiac activity, you can say that this is a failed pregnancy. And if the mean sac diameter is 25 millimeters or more, and without an embryo, this is a failed pregnancy. Here is the same source, CPG, from OB ultrasound, which lists the sonographic findings of suspicious for failed intrauterine pregnancy. And these are the following. So what can you actually do when you are faced with a suspicious finding? So this is very important and very crucial so that you will prevent the mistake of misdiagnosing a potentially viable pregnancy. So in general, we remember the three structures: the gestational sac, the yolk sac, and the embryo. So in one scenario, if you encounter a gestational sac with no embryo and it measures less than 25 millimeters, you wait, you repeat for ultrasound after 2 weeks, and if you get the same findings, then that is labeled as pregnancy failure. Now, if you have a gestational sac and with a yolk sac, okay, and no embryo, you repeat the ultrasound after 10 days, and if on repeat you still have the same results, then that is labeled as pregnancy failure as well. For the third scenario, when you see a crown rump length of less than 7 millimeters, it's given, there's a gestational sac, there's a yolk sac, then you see the embryo, and it's less than 7 millimeters and with no cardiac activity, you still wait for 10 days again. Then if you get the same results, crown rump length regardless of the size, and you have no cardiac activity, then this is pregnancy failure. So first trimester scan is generally not a routine procedure unless it's indicated. Several studies propose that the timing of first trimester scan is preferably done at 11 to 14 weeks gestation. There are several guidelines actually on how to perform first trimester scan. You have the American Institute of Ultrasound and Medicine, and you also have the first trimester examination of fetal anatomy. And the third is the ISO practice guidelines, updated versions with the performance of 11 to 14 weeks ultrasound, which was released early this year. So the ISO guidelines will describe the first trimester scan into 2 levels of screening. You have the minimum requirements, as you can see in this table, and the level 2, which is the comprehensive, detailed examination of the fetus in the first trimester. So here's a table summarizing the anatomical regions, the required views, structures to screen in performing the minimum requirements of the first trimester scan. This minimum requirement is also incorporated in the detailed anatomical scan based on the ISO guidelines, so that will be the one that I will be illustrating in the succeeding slides. So the detailed anatomical scan starts with general assessment for viability, for confirmation of intrauterine pregnancy, and get an overview of the fetus, the uterus, and the placenta. The BPD and head circumference are measured, In the larger symmetrical axial view of the fetal head, there are actually two techniques in measuring the BPD. You have the outer to inner or the outer to outer, and must be perpendicular to the midline facts. The abdominal circumference is measured in an axial section of the fetal abdomen at the level of the stomach, and the line is drawn on the outer surface of the skin. While the femur length is measured in the long axis plane of the femur, the calipers are placed either end of the ossified diaphysis. For the detailed examination of the head and the brain, the head is imaged in three different axial planes. The first one that is being shown here is the transventricular plane, which shows us a normal oval-shaped head, an ossified cranium, the interhemispheric facts dividing the fetal brain into two symmetrical hemispheres, the choroid plexus and the lateral ventricles. Abnormal head shape is seen in cases of anencephaly, especially when there's absent skull, and irregular in shape seen in exencephaly, and in cases of holoprosencephaly, the shape is circular. Abnormalities of bone ossifications include osteogenesis imperfecta and anatrophic dysplasia, and absence of wax and fused choroid plexus is seen in cases of holoprosencephaly. This is the second plane of the head and brain detailed anatomical scan in the transthalamic plane, demonstrating the lateral ventricles, the thalamus, the aqueduct of Sylvius, and the cerebral peduncles. An abnormal appearance of the cerebral peduncles and the aqueduct of Sylvius is commonly seen in cases of spina bifida. The third plane is an axial view of the posterior fossa, which again gives you the thalamus, the cerebellum, the fourth ventricle, and the cisterna magna. An increase in the fluid in the fourth ventricle may suggest Dandy-Walker malformation. We go now to the detailed examination of the face and the neck. We have three images. The first image is a mid-sagittal view of the head, demonstrating the facial profile, including the forehead, the nasal bridge, and the nasal bone, the maxilla, and the mandible. The second view is the axial view of the head, showing us the orbits and the lenses, and the maxillary processes and the nose. The third is the oblique coronal view of the fetal face, showing us the retronasal triangle and the mandibular gap. For the detailed examination of the thorax and the heart, one has to illustrate an axial view of the fetal thorax at the level of the four-chamber view of the heart. And you can see here the lungs, the rib cage, the thoracic aorta, and the intrathoracic position of the heart. You should also take note of the heart axis and the symmetry of the atria and the ventricles. This is a four-chamber view of the heart we call Doppler, showing the diastolic flow from the atria to the ventricles. And the next image beside it is the three-vessel and trachea view of the fetal heart we call Doppler, showing the direction of blood flow in the aorta and the pulmonary artery. Common structural malformation are the valvular atresia, your hypoplastic left heart syndrome, your tetralogy of Fallot, and transposition of great arteries. Here is an axial view of the fetal abdomen, showing the fluid-filled stomach in the left quadrant and the normal appearance of the position of fetal liver and the ribs. Another axial view of the abdomen demonstrating the intact abdominal wall and the site of umbilical cord insertion. Abnormalities in this image can be seen in omphalocele, gastroschisis, and body stalk anomalies. Here is an axial view and a sagittal view of the fetal pelvis, demonstrating the presence of the fetal bladder, the genital tubercle, and the diaphragm. Common anomaly seen is the congenital diaphragmatic hernia. Here is the coronal view of the thorax and the abdomen, showing the bilateral fetal kidneys, the thoracic lumbar spine, and the axial view of the fetal pelvis with collar Doppler, demonstrating two umbilical arteries encircling the fetal bladder. Common malformation are the megacystitis, your hydronephrosis, and your renal agenesis. For the detailed anatomical scan of the spine, this is the sagittal view of the fetal spine from neck to sacrum, and the skin should be intact overlying the spine, and you can see the ossified vertebral bodies. The most common anomaly is the open spina bifida. The next region are the extremities in two views. We have the coronal view of the bilateral lower limbs, and you can see the upper legs, the lower legs, and the feet here. And the next image is the axial view of the bilateral upper limbs, showing you the arms, the lower arms, and the hands. This is to rule out skeletal dysplasia and limb reduction defects. And the last region in the detailed anatomical scan in the first trimester is the placenta. The placenta should appear homogeneous without any cystic spaces, and if you apply color Doppler, you can demonstrate the umbilical cord attachment. You should also take note of the placental location in relation to where the cervix is and where the uterine cesarean scar is. So the first trimester anatomy scan was first introduced more than 2 decades ago, and standard protocols in performing this procedure are being updated regularly to improve detection rates. The detection rate of these procedures largely depends on several factors like the ultrasound system, the skill of the operator, and the prevalence of the anomaly being studied. In the systematic review by Karim et al., he found out that the overall detection rate for first trimester anatomy scan is at 41% overall. It's a little higher in detecting major anomalies at 53%, and 32% for the low-risk population and 66% for the high-risk population. These are 2 more systematic reviews by Liao et al. And Grady et al. Involving around almost 70,000 procedures of first trimester scan. And they found out that the prevalence of fetal anomaly is found to be between 3 to 3.2%. And the overall detection rate is between 43 to 49%. You can see that the detection rate is highest if one would examine the abdominal wall defects, the nervous system defects, and the limb and skeletal malformations. So now we move on to the last part of this lecture, which is the role of the first trimester scan in screening for aneuploidies. Aneuploidy is defined as a condition where there is a missing chromosome or an extra chromosome leading to unbalanced chromosome complement. Here in our setting, the recommendation is all women should be offered screening for aneuploidy, regardless of age. This is based on the CPG guidelines of POCs on obstetric ultrasound. There are actually several strategies to screen for aneuploidy, and Dr. Nicolaides made this breakthrough when he described the first trimester measurement of the nuchal translucency and its association with Down syndrome. A soft marker is defined as a transient, non-specific sonographic findings indicative of an increased risk of fetal aneuploidy and some non-chromosomal abnormalities. Aside from the nuchal translucency, other soft markers of aneuploidy in the first trimester include the nasal bone, the frontomaxillary angle, the tricuspid, and the ductus venous flow. So the term nuchal translucency was first coined by Nicolaides and his colleagues in 1992, describing the finding of an increased translucent region behind the neck of fetuses with trisomy 21. This sonographic marker for aneuploidy was subsequently validated by several studies and investigators and is now an integral part of the most first trimester screening tests for chromosomal disorders. And here are the guidelines in doing or measuring the nuchal translucency. Here is an example of a normal thickness of the nuchal translucency. And here is an illustration of an increased nuchal translucency. For the second marker, the nasal bone, it is absent in 60 to 70% of trisomy 21, in about 50% of trisomy 18, and 30% of trisomy 13. And the protocols for assessment or in the measurement of nasal bone is similar to the nuchal translucency, and these are the following. An abnormal finding would be an absent nasal bone, as this is normal, and this is absent nasal bone. The third marker is the frontomaxillary facial angle. This is formed between the superior surface of the maxilla and the frontal bone and is measured in the mid-sagittal section of the fetal face. In fetuses with trisomy 21, the FMF angle is increased, as seen in the image on your right. So these are the protocols for assessment of the frontomaxillary angle. Normal ductus venous flow shows a triphasic pulsatile forward flow with a normal A wave as seen in this line, encircled in blue. Abnormal ductal flow is observed in 5% of chromosomally normal fetuses and in about 80% of fetuses with trisomy 21. So this is the protocol for assessment of the ductus venosus flow and the settings for the spectral Doppler. Usually the A wave is assessed as positive, absent, or reversed. And here is an illustration of a reversed A wave. For the last soft marker, the tricuspid regurgitation, this has also been proposed as an adjunct to first trimester's aneuploidy screening. And this is your protocol for assessment. An abnormal finding would be a regurgitation of more than 50% at systole, as illustrated in this image. In the box CPG on obstetric ultrasound again, it reported the following percentages of fetuses with aneuploidy when this sonologic feature is seen. It is 80% for both abnormal ductus venous flow and tricuspid regurgitation. It's 75% for increased nuchal translucency and 69% for increased frontomaxillary angle. And it's 60 to 70 for absent nasal bone. Here is another table comparing the detection rates of aneuploidy when various markers and risk are combined. As you can see, the detection rate increases when another screening method is added. It is seen highest when all methods of screening are combined at 95%. This is a table taken from the ISO journal on the first trimester practice guidelines showing screening strategies for aneuploidy. A combined screening which involves the risk factor, the maternal age, the gestational age, the nuchal translucency, your biochemical markers in the first trimester, had a detection rate of 92 to 96.4 for aneuploidies. And if you add the ductus venosus flow and the tricuspid regurgitation in the combined screening, the detection rate is slightly higher. For the third screening method, they combined the cell-free DNA. These are your NIPTs, or non-invasive prenatal testing. They combined it with the first trimester anatomy scan with nuchal translucency, and they found out a 100% detection rate for aneuploidies. But when they combine the NIPT or cfDNA with the combined screening, it's slightly less than 100, it's 98.4%. The literature with the validation studies is overflowing for the first trimester anatomy scan. And the detection rates are very comparable with that of the second trimester anatomical scan. But there are still existing arguments with regards to its utilization as a routine screening tool for all pregnant patients. So in summary, first trimester ultrasound should not be done routinely. It should be an indicated-driven procedure, primarily to assess pregnancy viability, for accurate dating of pregnancy, confirm singleton pregnancy, and for further evaluation of pregnancy symptoms like bleeding, pain, or pelvic masses. An initial first trimester scan is preferably done at 11 to 14 weeks, allowing first trimester risk assessment using soft markers and the diagnosis of major structural abnormalities using standardized protocols. In some settings, though, first trimester anatomy scan is reserved for high-risk patients. I think this is my last slide. These are my references, and thank you all for listening.
Thank you, Dr. Precious, for the very comprehensive and lecture. I feel that listening to it, I don't have much to add. Maybe we can ask one or two questions.
You have very clear images of your first trimester scan. We can get this actually. There are new ultrasound machines using high frequency. And you don't have to do transvaginal ultrasound. I think the frequency is 12 or higher. Now, does it mean, based on your lecture, that the general sonology should strive to see fetal anatomy during the first trimester? Because right now, they are used to the second trimester screening.
The recommendation for anatomical scanning has been standard internationally. It is done at the second trimester. In doing the first trimester scan, as what I presented, the detection rates are comparable. But we have to face reality in our setting. I mentioned earlier the factors determining detection rates. One is how good the ultrasound machine is. If you don't have a very good ultrasound, actually, I have to disclose most of the images I presented are taken from the ISO ultrasound, and they have magnificent images there. The only images that was taken from our institution was a transvaginal video ultrasound that you saw. And happy na ako sa ganun. Yun, Doktora, we have to, if one can do it, if the health system or the institution can do it, why not? Number two, one has to be trained. There are structural anomalies that are very easy to detect, but there are others that are very hard. So training, ultrasound machine, and also the prevalence of the disease. If it's more prevalent, then it's easy to pick it up. But if it's something that you rarely see, it's very hard at all. For me, Doctora, I'm personally, it's the movement that we have to go forward po. First trimester anatomy scanning is very helpful. Siguro in our settings, no, in other countries, they allow termination, but here in our country, we do not do that. I think the advantage of this is we can prepare our patients more. You know, when we see anomalies, we can counsel them and refer them to other, probably a geneticist. Thank you.
Sometimes I see significant subchorionic fluid accumulation even at the lower segment, but the patient has no bleeding. So I'm wondering if that's subchorionic hemorrhage or unfused membrane. So what can we differentiate?
Actually, I did not include the subchorionic hemorrhage in the discussion. It will entail a lot of discussion. I'm not very sure of the category or if we have, what do you call this? We can say that this is normal or not. But if you see a hemorrhage, like for example, it separates the chorion from its attachment, I think it's better to go clinical. If the patient is bleeding and she has bleeding and that would be diagnosed as threatened abortion. There are actually, I have also experienced fluid seen, and some studies would say it depends on the ratio. If the fluid is bigger than the pregnancy lag. It's so much bigger than the gestational sac. So that would be probably a suspicious for pregnancy failure. But it's not included in the post guideline. So I think it warrants monitoring. If you see fluid there, there are ways to compute the volume, probably repeat it for another 2 weeks. But there's no actually a guideline on that. But I will probably go clinical. And I will take note, I will put it on the ultrasound result so that the attending physician or the obstetrician will be aware of it.
Since we are famous for trophoblastic diseases, as you do your first trimester scan, which image would show a red flag that possibly you have to follow up because this could develop into trophoblastic disease?
In diagnosing trophoblastic disease using ultrasound, they appear in variation, Doctor. It depends on the age of gestation. So I've mentioned earlier the criteria for diagnosing a pregnancy that is a failed pregnancy. And if it's a failed pregnancy, it's a red flag already. You have to rule out GTN or your gestational trophoblastic disease. And you usually correlate this with your beta-HCG levels. The classic appearance of a gestational trophoblastic disease, for example, your molar pregnancy, would be the snowstorm appearance. But not all GTNs, not all molar pregnancy will present as snowstorm. It really depends on the age of gestation of the patient. So there are many other factors for to consider.
Okay, that's all the time we have for this section of our lecture series. Thank you, Dr. Diaz. May I invite Dr. Cecil Martinez to join me and present these certificates. Dr. Comia, can you come up there? We have this certificate of appreciation to Dr. Teobahildo Comia for his services as speaker of this 21st convention of the PSUCMI, meeting today's challenges with innovative and intelligent ultrasound this week, March 18. Thank you very much. Picture. Thank you, Dr. Cunha. Dr. Diaz. Dr. Precious Diaz, thank you very much. This certificate of appreciation is awarded to Dr. Precious Diaz in grateful recognition for his service as speaker at this 21st Annual Convention and 25th anniversary, meeting today's challenges with innovative and intelligent ultrasound, this 18th of March 2023. Yes, thank you very much.
This for the pre and post tests which we need for our CPD units. Thank you, Dr. Obed. So we're now in the last segment, I think. So our next speaker is Dr. Maria Teresa Buenaflor. She's a consultant radiologist at the Asian Breast Center, Centuria Medical Makati, and Health Cube Clinics, Philippines. She's a visiting consultant at the Jesus Delgado Memorial Hospital, Perpetual Health Medical Center Las Piñas, and the United Doctors Medical Center. Dr. Buenaflor is a practicing radiologist with at least 10 years experience with fulfilled digital mammography, and more than 5 years experience with digital breast tomosynthesis and especially contrast-enhanced mammography and molecular breast imaging and intervention. Now she's really one of the persons that we look forward to listening to because she's active in collaborative work that uses innovations such as artificial intelligence to improve diagnostic accuracy. So let us all listen to Dr. Maria Teresa Buenaflor on integrating artificial intelligence in breast ultrasound.
Good morning, everyone, and thank you to PSUCMI for the invitation. And it is a pleasure to join you and an honor as well, as I met a few colleagues and friends. And so let me just start with, when people talk about AI, they sort of, the reflex is it going to replace me, right? So there are so many types of AI, and I'm sure you're all very familiar with ChatGPT and all that. Now, there is also a subtype of AI called generative AI, and there are currently around 30. This is one that you want to try. So it's called stablediffusion.web. So I just type there and it generates an image. So it's pretty simple, right? So I typed there the fear of artificial intelligence and it gave me this nonsensical images. Right? So now that you realize that, is AI really as it's hyped to be? Or what are its potential solutions that it can provide us? Now, from the American Association of Medical Colleges, they note that there's really a widespread shortage of radiologists worldwide. We couple that with increasing workload because of the faster acquisition of your images from a lot of these more advanced machines. We are really going to be prone to burnout and a lot of medical errors. So this is where is there a role now for AI to help us in this sense? But to give you an overview, AI basically is just a set of tools and programs that will mimic how a human thinks. So a subtype of AI is called machine learning. So this is the process that the computer systems will follow to achieve artificial intelligence. And within this, what makes up is really the neural network. So these are basically just networks of algorithms, much like what you would encounter in, let's say, YouTube. But the basic neural network is usually comprises of about 2 or 3 layers, which I'll show in the subsequent slides. But the more advanced type is called deep learning, and these are nested algorithms within these layers, and actually will form the basis for most of the AI tools for image interpretation. So if we go through this in just a simplified diagram, I'm not IT, I'm also not in developing AI and all that. I like to validate AI. So we look at the machine learning looks at patterns, and then from that it generates a data model, and then it makes predictions, right? So let's say in YouTube, it will predict what you are most likely going to be interested in watching based on what you were previously viewing. So if you're guilty of looking at BTS, it will suggest Blackpink, something like that. So now you need to train them on subsets of data. So it can either be supervised, unsupervised, semi-supervised, or reinforced. Now, talking about these neural networks, see, as you can see here, so these layers here, so they form, this is very basic, it's just 2 or 3 layers. So these layers here, the multiple hidden layers, for example, you are training images. So first, it can either be just pixels. You start with pixels, now you can move on to the edges, Then you can look at individual features until such time the AI is now able to recognize actual images. So that is like a very simplified way of showing how the AI is developed. Now the deep learning algorithm, which is the basis for most of your AI tools, is actually just a lot of hidden layers within those layers. Now we really can't escape AI now because in the applications in radiology, in breast it comes in third, the first being the applications in neurology, and in chest imaging. MSK is around 10% also. Okay. Now this actually not just applies to breast imaging, but it is also can be applied to all types of specialties or body imaging. So there's two kinds of AI. So if you will be using them prior to image acquisition or during the image acquisition, image interpretation. So the broader upstream AI has something to do with administrative, tedious, the boring tasks. So it has to do with scheduling, protocol, image quality improvement, monitoring, and scan reading prioritization. But for the image interpretation or narrow AI, has something to do with the detection, the diagnosis, triaging, segmentation, can even be for treatment response prediction and risk prediction. Now, one application, just to show to you, is that of improving image quality by noise reduction. So this, for example, in this diagram, it shows to you that the greater detail of the tissue structures is generated because they remove some of those unnecessary signals. So now you have better image quality, and this is something that is going to be automatic. And I think this is going to be a very useful feature. For example, looking at the ducts in the breast. Now, if you're able to see more of the edge, it is easier to follow them and not misinterpret them for something else. So this is just an example for improving image quality. Now, moving on, for the clinical tasks of AI in breast ultrasound, it can either be in the detection, so either localization, segmentation, in the differential diagnosis, or in the prognostication. Okay, but before you want to start or even look at or evaluate an AI, it's good also to understand how that AI was built or how it was designed. So a robust AI model for ultrasound should be of large-scale data set. But before you get to large-scale data set and multi-institutional, you usually will start with a single center. So that's really how it does start. Now, it's also good that the images should be obtained from multi-vendor ultrasound machines. The more machines that it gets their images, the better. And it should also be trained on or has looked at a wide spectrum of diseases, not just pathologic, so normal and disease images. So, and also images from handheld ultrasound and automated ultrasound. Because AI is a data-driven technology and its performance is highly dependent on the quality and the quantity of its training data. Now, this is an example of what is also being done. Aside from that, when they train now the data, they do data augmentation. So it's really just a process of creating new data by the same image by data manipulation. So to simplify it, it's take one picture of that image, flip it around, do it vertically and all that, but to make sure that the AI is still able to recognize that same lesion regardless of how many times you've looked at it in so many different ways. So that is so that the machine is also able to identify that it's still the same lesion, right? No matter how you manipulate it. Okay. So this, next is when you are evaluating the AI, first it really is, it's in this manner. So it's going to be retrospective, prospective, continuous real-time testing. Now, the easiest, I think, the simplest to begin with is really to pit it against the ground truth, whether there's cancer or no cancer, and what is the performance of the radiologist. Then it undergoes internal testing for where the data was trained on, and external testing, meaning you test it in another setup or institution. Now, for this study, what they did was, this was the use of AI support in the classification of breast lesions. So these are all biopsy-proven benchmarking data set of about 5,000 plus patients and about 7,000 plus breast ultrasound images. Then they ran it, then they used this convolutional network, and the number of lesions, whether benign or malignant, are these. There are more of the benign because you also don't want to enrich your data set with malignant cases because that would skew it also. So when they looked at it using augmentation and without augmentation, the area under the curve was still very high. So that means the network was trained to differentiate, was able to differentiate the benign from the malignant very well. So again, another example of this is, I think in the workshop later, there's a machine where you can also try this one. So this is actually a semi-automatic lesion extraction, wherein it also has the guided lexicon for biogas. Now, it will tell you it will automatically segment this, but that does not mean that you let all of the AI do the work. Because if you don't agree with what the AI is picking up, you need to edit also the features, right? So to me, if you're just starting, you want to validate it, you can save whatever the AI annotated or diagnosed, and then you make your corrections. Then you compare if you both agree or you don't agree. And then the final arbiter is your histopathology. Now, as a clinical decision support for this lesion, for example, most of the readers read this as benign. But the AI read it as microlobulated, and this was actually upgraded to a 4A. And this was a diagnosed invasive ductal carcinoma. So this is in effect one of those that, okay, you may think it is, right? But if the AI, you cannot also discount what it says. But as I've said, since it is still in the training phases, you still need to do this and correlate it with the histopathology. Now, when they looked at the impact of the AI in the decision support in a multi-center retrospective review, this is of about 900 lesions, and the images were obtained from 5 different ultrasound vendors, right? And the ones who participated were all partly clinicians, 2 surgeons and 2 OBGYNs, and 11 radiologists, which is actually perfect because this is the perfect symposium to do that. And now you see that this is the distribution of the benign and the malignant cases. There are more benign cases than malignant. So this particular AI support system was trained on more than 400,000 clinical examples from more than 25 vendors of ultrasound machines and from 25 different healthcare systems. So knowing that these lesions were not part of this, so now you know that they trained in this many number of cases with this wide variety of ultrasound machines with this many institutions. So now if you run it from an external testing viewpoint, then you want to see whether is it going to perform similarly. So what did they do? So they looked at 900 cases. The first 750 cases were randomized as ultrasound only or read as ultrasound with the decision support, with the AI. After a washout of 4 weeks, the same 900 cases, but this time they were switched in the reading conditions. In the 750 cases, those that were ultrasound only were now read as ultrasound with AI, while those that were initially read as with AI were now read only as ultrasound. But the control are these 150 cases that were not switched in their reading protocols. And what did they find out? Their main reader, AUC for ultrasound only, was 0.83, compare that with the decision support that it's 0.87. So that was actually pretty good. And they found that there was better AUC in about 14 out of 15 of the readers. So this is an example again that for this small lesion, most of the readers read it as benign or probably benign, but the AI identified this as suspicious. And AI was actually correct in this sense because it turned out to be a 4 millimeter invasive ductal carcinoma. So I'm not saying that AI is better, right? I'm just showing that it can change your decision on how you want to classify these patients because you might want to upgrade or downgrade them as you do it. Now, new exciting technologies are actually in the upcoming, right? So this is one of those. This is actually a portable, wearable, 3D automated breast ultrasound scanner. So this is now a point of care, reproducible breast ultrasound imaging. So you wear it, it's worn like a bra. And what's really good about it is that it uses water as its medium. You don't need a gel. So they put the water in, it covers the breast, right? They wear it like a breast or they lie down. And then it will take 3D imaging of this one. So now, because it is point of care reproducible, if, for example, as a follow-up, they scan the same area, knowing where the lesions are from the prior exam, it will automatically go and identify those specific areas that were previously identified in the prior study. So that makes it very easy to follow, especially when you're monitoring a lot of this, or if you're using this in oncology for following post-neoadjuvant chemotherapy patients. Now, another example of, they probably improved the images already, because this was like 2 years ago. But as you can see, it gives you dimensions, it gives you also depth and all that. So this is how the images will look like. Now, what is next for artificial intelligence in breast ultrasound? Now, this is very interesting because now we're looking at, now there is a legislation in the US that you need to inform women of their risk if they have dense breasts, right? So dense breasts are this, that there's more fibroglandular tissues because there is a risk, there's a 4 to 6 times risk of breast cancer if a patient has dense breast. But beyond the breast density, there is now that they're identifying a new imaging marker that is only seen on ultrasound, and that is that they can probably use it as a breast cancer risk assessment. And this is using the internal echogenicity pattern on ultrasound. So typically, when you write the report on ultrasound, you have to describe whether it's homogeneous background echo texture. The background echo texture is homogeneous or heterogeneous. Homogeneously fat, which is similar to what you will see on the mammogram, or homogeneous fibroglandular, same as this one. But you will also see heterogeneous, so there's a good mixture of that. However, when they were, as they looked at some of the studies, there's now what you see as the glandular tissue component, or the GTC. So the ultrasound can be used to distinguish between the glandular and the stromal tissues based on their echogenicity that is not possible on mammography. So what they also see is that as there is progressive lobular involution of the breast tissue, there is a reduction in the risk for developing breast cancer. So if you look at both of these mammograms, both look at dense breasts, but the echogenicity are so very different. So here you have one that's mostly stromal in component, while here it's more of glandular. And you can see the correlation in the histopathology. This one has mostly involuted, while this still shows a lot of, the number of acini per lobule is still more or less the same. So when you are encountering, so what is the implication? For example, when you're encountering postmenopausal women but with dense breasts, right? You will see, oh, you might be at increased risk. But what if the glandular tissue component is actually already on this end? So probably the risk assessment might be different. So I will caution this as a new imaging marker because you will still need to have a lot of clinical validation. So what they found out in a study, a retrospective single study that was done in Korea with about 8,000 plus women, was that the incidence of breast cancer in women with a high glandular component was significantly higher than that with low glandular component. So from this retrospective, there is now a prospective multi-center study being conducted involving Asia and Europe of about 16,000 plus women, and they will look at the same if it's going to be showing the same as well. And again, another exciting field that's going to come out is now ultrasound radiomics. You know that in precision medicine, you're hearing a lot of this multi-omic studies. So this is now a technique for extracting high throughput quantitative features from your medical images. So again, looking at your raw images, if you run it in big data analysis technology, it looks at what features it's going to extract that's most likely going to be predictive because it will provide the clinician with high-dimensional quantitative data. Let's say which patients are going to respond really well to chemotherapy, what is the axillary lymph node status of this patient, so on and so forth. So in the future, ultrasound radiomics should be combined with clinical data and microscopic data as well, so that you can accelerate breast cancer research, especially in precision medicine. Now, for those who are actually interested in getting an AI software or AI system, right, I would direct you to the ECLAIR guidelines. So this is basically how to evaluate a commercial AI solution with these parameters, right? So to whom it is relevant, what is its performance and validation? So which is very important. These are very important questions that you need to ask the vendor on what data set was it trained on, how many, what machines, all of those. So these, they have to answer what is its usability, integration, and these are some of the aspects that need to be discussed as we go on. So now begs the question, will the radiologist be replaced by AI? Or even for clinicians who are performing ultrasound? I don't think so, because the challenge here is not to oppose its incorporation, but to incorporate it into your workflow. You will always be on the side of those who are quick to adapt to technology. So I would like to end my lecture with this. Again, I typed again, AI in medicine. So it came up with this. And I was actually surprised because I think I saw the same image on the PSUCMI website. So which I think now you see, I think AI still has a lot to learn, but at the same time, we also have a lot to learn. So we need to keep up and keep abreast, literally. Okay. Thank you so much.
Okay, so thank you very much, Dr. Benaflor. Do you have any questions?
If no questions, you're free to approach me.
Yeah.
I'll be available to take your questions on the floor.
Yes. So anyway, so really there are no questions. So I just like to get to say that artificial intelligence, as this whole convention is really about, let us learn about it also and see where it can fit in our practice. As they said, it should be helpful to us. For doctors like Dr. Benaflor, who's already very well trained, actually AI might just be like, okay, she'll just compare it. But for us who are not really breast radiologists, but general radiologists who are forced to do it because we don't have any breast specialists in our area, I think AI is really definitely of use, right? So thank you very much, Dr. Benaflor, for the wonderful lecture. And it's now time for us to have the certificates. Okay, so this certificate of appreciation is awarded to Dr. Maria Teresa Benaflor in grateful recognition of Invaluable Services speaker for the 21st Annual Convention and 25th Anniversary Celebration, meeting today's challenges with innovative and intelligent ultrasound given March 18, 2023 at Century Park Hotel, Manila, Philippines. Signed, Dr. Patria Cecilia Martinez, President, and Dr. Millicent Tan Ong, Overall Chair, Organizing Committee. Is this the final module? Yeah, for the musculoskeletal side, and I'd like to call on the moderator, Dr. Svetlana Marisa Icardo. She's a board member of PSUCMI, and she's part of the Philippine Society of Clinical Musculoskeletal Ultrasonography. Okay, our PSUCMI.
Thank you. We've had a very interesting morning, right? So for the musculoskeletal module, we have two great speakers. And you know, PSUCMI is really a slave driver, because from a moderator, we now ask Dr. Obet-chan to be our lecturer. So Dr. Robert Obet-chan is an orthopedic surgeon from the University of Santo Tomas. He is also a consultant of Premier Medical Center and visiting of Cardinal Santos. He is the chair of Takusagam. Yes. And he heads the musculoskeletal SIG group of Philippine Orthopedic Association. So later, we will take a peek of his AI brain. Okay. And then our next speaker, which will be via Zoom, or video recording, is Dr. Levent Özkatar. He is the founder and president of the Turkish Musculoskeletal Ultrasound Study Group, the European Musculoskeletal Ultrasound
Recording in progress.
World Musculoskeletal Ultrasound Study Group, the Turkish Multidisciplinary Ultrasound Society. He is the president of the Ultrasound Task Force of ISPRM. And he heads the Special Interest Scientific Committee of ESPRM on musculoskeletal ultrasound. He also has published and reviewed various journals and publications. So to begin our musculoskeletal module, Dr. Obet-chan.
Thank you very much for that kind introduction. They had no choice. They had no other choice but to ask. This is my lecture. Not the weights, those are not muscles, those are not, Good morning again. These are my disclosures. So I have only intelligence and it is artificial. That's why they chose me to be the speaker in this AI conference. So whenever we talk of AI for the musculoskeletal ultrasound, in the shoulder, usually it is used primarily, AI is helping us to diagnose, to help classify, and to segment. As you have seen this again and again, more or less it's just to streamline the pictures that we gather among ourselves. And ideally, it should be collated as much as possible, and it should be critiqued so that each one of us will have the same diagnosis with the same picture ideally. That's the main goal of AI, is to allow us to all share in the knowledge of finding pathology and trying to treat it. And in the aim of musculoskeletal AI, presently for orthopedics, as you have shown, it is 10% of the whole gamut of AI. Most of them are used for muscle, so they help in determining muscle dystrophy and muscle sarcopenia now. For osteoporosis, they are now trying to do that in their papers. Then they are trying to use it for hip dysplasia of the hip, developmental dysplasia of the hip, and synovitis scoring for rheumatoid arthritis. So they are now trying to standardize because there are many classifications for rheumatoid arthritis, so they're trying to standardize it to allow us to better monitor and treat our patients. And for spinal level of intervention, because sometimes it is very important to know where to put your needle when you do intervention in ultrasound guidance. So this will more or less help us determine the proper level and the proper depth in putting our medications. And of course, nerve segmentation for nerve pathology, so it will tell us where usually to look for the nerve, because sometimes remember that we see nerves as honeycomb pattern, but there are certain nerves that have only one monofascicle. So it's very hard to look for it. So with the AI, it will help us try to see and know where to try to look for that specific nerve if you want to do intervention for that. And of course, cartilage segmentation to determine the degree of osteoarthritis for us to help predict what to do with the patients also. So my task is to talk about shoulder pathology, and for the shoulder, there are very few AI papers, so I will discuss this later. But I will now be talking more of the traditional ultrasound scanning of the shoulder pathologies. So again, this is just a quick review. I hope you will not be bored with this. So this is the front view. You can see the biceps tendon. We all know that the subscapularis for the rotator cuff, the subscapularis is anterior to the scapula and it inserts to the lesser tuberosity. The reason why I'm doing this is just to orient us, because whenever we look at ultrasound picture, we always have to look at the bone and the attachments, because that's very important. Then the supraspinatus, which is in the supraspinatus fossa, supraspinous fossa of the scapula, it inserts to the greater tuberosity of the superior aspect. The infraspinatus is at the under the spine of the scapula. Under that is the infraspinatus, and it inserts to the greater tuberosity posteriorly, and the teres minor at the inferior portion. So as we can see, we only do not look at anterior and posterior, but also in the normal orientation, because it's actually not just pure lateral. In the anatomical position, the scapula is in an oblique position, so that whenever you try to look for the long axis of the structures, you have to follow the anatomical, because sometimes we all know that you just move the transducer a little and you will lose the picture. So putting the transducer in the proper anatomic position will give us the best view, and if we all do this, we can collate all of this and form the AI that we want. Now, whenever you do your scan, take note that this is not ergonomic. Please take note that I am a bad example, because the ultrasound is here and the patient is here. Yung relative ayaw umalis dun eh. So the relative does not want to move. Sabi, okay na ako dito, Doc. Eh, hindi ko naman makaalis. So the patient is here, and take note that whenever you put the probe, Dr. Buffard always tells us, our mentor for musculoskeletal ultrasonology, is that whenever we do scanning of the shoulder, ideally you have to have a series. You start with certain steps for you to know what it is in the line of your study. Because you always start with the bicep, then the subscapularis, then the acromioclavicular joint, then the supraspinatus, because the subscapularis and the supraspinatus tendon both look like a little like a bird's beak. So it will differentiate. So the break with the AC joint will help us determine what structure we are looking at. Then after the supraspinatus, you go to the infraspinatus. Then you look for the other states. So again, just bear with me. So always remember also, probe position is very important. We all know that ideally you put the positioning of the probe, the indicator, to the left of the examiner or the right side of the patient. So whenever you look at the screen, you know that this side of the screen is the right side of the patient. So for the short axis view, if you look at the anatomy, this is the greater tuberosity, lesser tuberosity, subscapularis muscle, and the bicipital groove is where you look for your biceps tendon. And across that is the transverse ligament, and sometimes the superior glenohumeral ligament is also there. So you have just to remember these structures. And whenever you see these structures, you always have to scan. Always remember that it is not static. When you see the tendon, you just don't stop there. You have to go up and down because sometimes the pathology is in different areas of the anatomical part. So whenever you do the scan, as you can see, this is the long head of the biceps. If you go more superior, the bone will be flatter. If you go inferiorly, you will have a shallower groove. Then if you go more distally, it will again flatten. So you have to look at all these things and look at the tendon as a whole. Then also remember anisotropy. Remember that whenever you tilt the transducer, the tendon might show up, then it might disappear because the distribution of the ultrasound, as we all know, is deflected. And if it is deflected, it does not go back to your probe, and it will, the machine doesn't know that. It will just tell you that less ultrasound signal is going back to me, so there must not be something there. That's why whenever you do ultrasound, you have to always remember that you are the one that are creating the image, and you have to do it properly. And as we all know, in a direct perpendicular to the structure, most of the ultrasound is reverted. More of the ultrasound is reverted back to the transducer, which will give you the signal. However, there are some signals that still continue, and that is sometimes lost. So if there are other structures here, it will just bounce back and show you the other structures. However, in an inclination, as we all know, some will be deflected. That's why it is anisotropic. However, depending on the structure also that it hits, it might be deflected at a different angle. So you see that this one is angled here, so this signal is lost also. I guess this is what was said earlier in the yesterday, yun sa mind ray, yung edge artifact. The edge artifact is lost in their machines because I think the computer compensates for that. So that's AI again. Now, whenever we think of pathologies, we have to look for the anatomic versus the pathologic. So you saw earlier the anatomic, but now you can see that this is the biceps tendon, this is the bicipital groove, and then you have this one, anechoic structure here. So this is fluid or blood, no? So, or synovitis. So there are different things. Remember, there are different things that can cause anechoic in a picture. But this is your target site. If you try to compress it, if it is compressible, most probably it's fluid. However, there is a possible problem there because if the pressure of the fluid is too high, it will not compress. So that's one of the caveats. Because technically, if it is compressible, it is non-compressible, you think of it as a synovial tissue. However, if you have a super distended tendon, capsule, it might be non-compressible because of the fluid. So those are the things that you probably have to think of. What you can do is you can put Doppler, and when you put Doppler, you can see the blood vessels. If there is blood vessels, most probably it's synovitis. If there are no blood vessels, most probably it's fluid. So you have to use everything in your armamentarium to help you. So as you can see here, the long head of the biceps, the fluid, the transverse ligament is already distended, and the superior glenohumeral ligament is also pushed up. Sometimes, because of the chronicity of the fluid, it goes into the tendon and it dissects the tendon because whenever you have a long-standing fluid in a tendon, the fluid tends to be imbibed by the tendon and sometimes it causes a cyst inside. So you can see that there is the fibers, you can see the you saw the fibrillar pattern. Now you see the fibrillar pattern of the tendon and now you have the cyst inside, as compared to the normal. So you have to always compare this in short axis and long axis for you to determine, but we're talking about short axis lang. I will show you the long axis later. So whenever you see this, you think of a possible cyst inside the tendon. And sometimes you have to distinguish the fluid inside the tendon against the fluid outside the tendon because sometimes the fluid then transverse up to the subacromial subdeltoid bursa and it can also proliferate. So when fluid is on top of the transverse ligament, you know that it is not on the tendon. But if it is under the transverse ligament, you know that the fluid is in the tendon. another problem with the chronicity of the exposure of the tendon to the fluid, it imbibes the fluid, and what causes it? It causes tendinosis or tendinitis. So what is tendinitis? Inflammation. Inflammation of the tendon. So there is increase in the size of the tendon. How do you know it's increased? Always compared to the contralateral. Whenever you do musculoskeletal ultrasound, ideally you compare it to the contralateral side. Ideally, it should be different for the pathologic unless the pathology is bilateral, which is common in systemic problems. So you have to be careful with these things. Then of course, aside from that, because of the long-standing edema, it causes some rupture in the tendon, and sometimes it causes flattening of the tendon. And because of the flattening, because it nasa-squish siya, because of the constant range of motion, the tendon is being compressed, so it becomes compressed and it sometimes herniates outside. So these are the things you have to look for. And because of the chronicity, because of the constant irritation, the tendon will eventually rupture. So what happens is you have your pop eye sign. So pop eye sign is because of the transection of the long head of the biceps, the muscle contract. So yung Popeye, the sailor, di ba? So this is your Popeye sign. So how is this in ultrasound? You can see the empty bicipital groove. So there is no more bicipital groove. Make sure that you try to look for the fibrillar pattern, because this is just synovial and fibrosis. So this is synovial and fibrosis. This is not the tendon. So you know the speckled pattern, the brush. It's like when you cut a brush, no? Yung brush border. That's how tendon should look like. And if you look from distal to proximal, so distal to proximal, you can see that here the humerus is flat, the humerus is round. So this is really distal. So you see the biceps. Then you see the bicipital groove, that is the biceps. Then the bicipital groove, as you are going up, you see that the bicep is already decreasing in caliber. So this is the area where probably there is a partial cut or it's an oblique cut. And here you see that there is no more tendon. So you have to really scan up and down. Now after the short axis, always compare on the long axis. So this is how you do it. So remember that the probe indicator should be facing cephalad. So whatever is on the left side of your screen is the cephalad portion. So whenever other doctors see this, and for AI, we should always have a standard of scanning for us to do a proper examination of the shoulder. So take note also that in the after you see the tendon in short axis, you rotate it 90 degrees where the indicator is superior. So you look for that fibrillar pattern, the whole fibrillar pattern of the tendon. However, take note that this is a little oblique. This one is a little wider than this one. So this is again your anisotropic effect. So again, this is your deltoid muscle, this is the long head of the biceps, this is the humerus. As you can see here, as I said earlier, this one, the tendon is not so well seen. You can see the fibrillar pattern because it is oblique. Do not stop there because you might sign this out as tendinosis kasi hindi maganda yung fibrillar pattern. But if you just move your transducer, you can do two things. You can move the patient or you can move the transducer. Because remember, if it is 90 degrees to the structure, you create a better signal. Just as little as 7 degrees of deviation from the perpendicular and it will already scatter the image. So you can have already a poor signal. Or what you can do is you can tilt the transducer if the structure is oblique. Look at this, if you do it still, matigas ang ulo natin, we still use it in a straight position, you will not get a good image. But if you tilt your transducer to at least almost parallel to your structure, you can have a better picture. Now take note, remember the target sign we said earlier. You can see that there is a effusion superior and inferior to the biceps tendon. And take note that because fluid allows more ultrasound to pass through, the image in the inferior portion beyond the fluid increases in echogenicity or increases in structure. And always remember that the pectoralis major goes over the biceps tendon and attaches to the lateral aspect of the bicipital groove, no? So that is the attachment of the pectoralis major. That is why there is usually a cut off here where the pectoralis tendon prevents further effusion downward. As you can see also, this was the earlier picture of the tendon with the fluid inside, the cyst inside, and you can see that there are still some fibers that are intact, but there is a large fluid. This is an impending rupture, usually in degenerative patients. As you can see, this is compared again to your normal. Now, when the tendon ruptures, what happens? There is loss of signal, no? But you have to again make sure that this is not anisotropy. So you have to tilt your transducer. So if you tilt the transducer and it is still absent, this can be a possible tendon rupture. However, if you see that the fat is already herniating down to the humerus or the bicipital groove, it is more indicative of a higher indication that there is a biceps tendon. And you can see the stump here. Take note also that you have to be longitudinal because sometimes you just put it obliquely, then you think that you are just cutting the tendon but in an oblique position. So you cut some of the tendon, then you lose the tendon. So you might think that it is always, it may be cut, but it is not. So your position is very important. That's why AI probably will help us if you use a 2D echo, the 3-dimensional probe. That would give us a global picture of the tendon without moving your probe. Then if you look at the long axis view, if you do range of motion of the biceps, you can actually see the movement of the tendon and the movement of the tendon going up and down because it's not already connected. Now the next structure that we will look at is your subscapularis. In the anterior portion, remember that the subscapularis inserts in the lesser tuberosity, however, it is inserted obliquely. That's why you have to external rotate your arm to further stretch it and bring it forward. And because if you look at it just obliquely, it will just be black. Remember that tendon in an oblique position because of anisotropy will usually appear black. So this is your subscapularis tendon. Look, it's just like a small beak, no? So this is the lesser tuberosity, this is the deltoid, this is the coracoid. So coracoid, lesser tuberosity, deltoid, this is the subscapularis tendon. Take note that as you are moving the tendon, it becomes black, and as you external rotate, it becomes white. This is the coracoid. No? So take note also that the fluid does not bunch up as it is going. As you are going to internal rotation, and that the tendon itself is not getting caught between the coracoid. So these are the things you have to look into. And of course, aside from that, you have to take note of the normal, ideally normal. So in cadaveric studies, it is usually 5.5 millimeter in thickness. So that's why whenever you look at the ultrasound, more or less when you take the thickness, it should be at least 5.5 plus minus 1.3. Then 80% of all subscapularis there is in concomitant with the supraspinatus. So if you see a subscapularis there, try to look for a supraspinatus there. And usually the superior glenohumeral ligament and coracohumeral ligament are also torn because as the subscapularis is inserted, it is blended together with these two ligaments. So when it gets torn, it drags those two ligaments with it. And majority of all subscapularis there, because most of it is fall from a height with a protected arm. So as the humerus is being propelled up, the subscapularis is torn from the superior medial going downwards. Then if you have to compare the normal, because all patients don't have the same thickness, you compare it to the contralateral side. If the tendon is greater by 2 millimeters, most probably it has tendinosis. Now, as we have said earlier, usually if the tear is in the superior portion, so if it is in the superior, it is type 1, going down to type 2, type 3, type 4. So this is the Lafosse arthroscopic. This is an arthroscopic evaluation, and we can compare it ultrasound-wise. So as you can see, these are partial and full thickness tear. This is a partial tear on the lesser tuberosity. You can see that the tendon, because of the retraction, becomes further hyperechoic. This is a full thickness tear. This is the hyperechoic tear, and because of the contraction, it gets bunched up. Then you have this articular sided tear of the tendon, and take note, this is the humeral head, so this is the lesser tuberosity. Usually it should be until there, but you can see that there is already an anechoic portion here. This is a complete tear. As you can see, there is an anechoic area in the lesser tuberosity, and if you look at it at short axis, it can be a complete full thickness tear, and this is a naked tuberosity sign. And because of the constant irritation of the synovial fluid on the lesser tuberosity, it causes irregularities of the bone or an arthritic change already. Now for the asymptomatic side, the subscapularis is like this, but this is a empty wheel sign. You can see that there is no more subscapularis here. Then, of course, this is a full thickness subscapularis, which is seen also in MRI. And if you look at the short axis view, you look at the different bundles of the subscapularis. So that was the long axis. So this is the humeral head, this is the cartilage. Remember that the cartilage is very hydrated. That is why it is very anechoic. So this is the hyperechoic subscapularis, and this is the deltoid muscle. And again, as we have said, look at the different bundles of the... Before we were taught that there were only 3 bundles, but now we know that there are more bundles. No? So the bundles that you see here, these are not tears. Do not mistake this as tears. These are just bundles of your subscapularis tendon in the lesser tuberosity. And sometimes you can have effusion. And when you have effusion, you have to put compression. This is compression, and when you release it, you know that that is effusion because it goes back, it pushes the fluid pushes back the subacromial subdeltoid bursa up again. So you know that this is not synovitis. Then after that, remember biceps, subscapularis. Then you, between the supraspinatus and subscapularis, always look for the coracoacromial ligament, acromioclavicular ligament. So if this is the normal clavicle and the acromion, so the clavicle, acromion, and this is the normal coracoacromial ligament. So you put it long axis, as you can see, this has effusion already. So there is lifting. Normally it should be straight, but there is already lifting of the coracohumeral ligament. And if you look at this, because of the fluid, you can actually see the supraspinatus muscle under. So these are the things that you have to look for. You have to look for narrowing of the joints. If there is narrowing of the joints, there is arthritic changes and cortical irregularity. Ideally, these bones should be smooth, but because of the chronic irritation, it causes fuzzy and irregular changes in the cartilage. And if you do a cross-arm test, you put your hand on the contralateral shoulder. Ideally, if there is effusion in the subacromial subdeltoid or effusion in the joint, it will cause ballooning. But if you take note, as the patient is moving, you can see the supraspinatus muscle moving here. There is no ballooning, so this is negative for tear. Usually, if you have a supraspinatus tear, this is more positive. So what do we do for these patients who have arthritis of the AC joint? Because usually it's very painful also. You can do needle insertion, you can put steroids or PRP, whatever you like. So this is your needle, and you have to make sure that it is inside the effusion and inside the joint. So you use ultrasound as your guide. And you can do it out of plane or in plane. So this is an in plane with the long axis. This is the out of, this is the out of plane. So you can see that this is the small round thing is your needle, and this is the trajectory of your needle. Now for the next structure, you look for the supraspinatus. Take note that the supraspinatus, this is the bird beak pattern. It is an anatomical representation. 1 millimeter representation of your anatomy. That's why I said earlier, yesterday that as you are moving your transducer, you are cutting actually the patient 1 millimeter at a time. So it is better, not more dynamic to use instead of the pre-cut segments of the MRI and the CT. The MRI and the CT kasi you have to make sure that you get the smallest possible cut to find pathologies better. So that is the beauty of ultrasound for me. So if you take note, this is the greater tuberosity. This is the attachment of the supraspinatus. Take note that this is the cartilaginous area of the humerus where the cartilage, anechoic cartilage is. And usually the end of the supraspinatus is where the start of your cartilage is. So this is your supraspinatus. So whenever you think of supraspinatus, the space between the acromion and the clavicle and the humerus and the muscle is your subacromial subdeltoid bursa. So this is a potential space which tries to lubricate the movement of your shoulder. So it is very vascular. So if you irritate it very often, it will cause an inflammatory reaction and hypervascularity. It has a very high growth factor and a very large progenitor potential. So if it can repair itself ideally. Now, pathologic problems, because sometimes the acromion in normal individuals, it is straight. However, there are patients that has a hook type of acromion. So that's why whenever you are moving the humerus, it abrades the subacromial subdeltoid bursa, causing inflammation. And if you have inflammation of the subacromial subdeltoid bursa, you eventually will have inflammation of your supraspinatus tendon. Then, actually, repetitive overhead injury, yung mga labandera, yung mga teacher. So, direct trauma, crystal deposition, gout. Gout and calcium pyrophosphate can cause inflammation of your synovium. Fluid because of hemorrhage, infection, and autoimmune disease all have a predisposition for arthritis for these patients. So in trauma, as you can see, this is the tendon and this is the subacromial subdeltoid bursa. No? This is the deltoid muscle. So whenever you see the tendon, this is a accumulation of fluid, and usually if it is blood, you can see that it can, if it settles down, it is hyperechoic. If it is starting, it is homogeneous. However, with a long standing, it becomes an organized hematoma. So these are the things that you have to look for. When you think of pathology, you always have to compare the one from the other, as we have said earlier. And if you have increase in thickness, more than 2 millimeters to the contralateral side, where do you usually measure it? You measure it between the junction of the cartilaginous portion and the greater tuberosity. Ideally, this is where you measure it for standardization, and you put it perpendicular to the long axis of the greater tuberosity. So if you compare one side to the other, if it is greater than 2 millimeters, most probably there is tendinosis. And of course, sometimes there are some people who have predisposition for calcium to incorporate into the bursa, you can have accumulation of calcium. And as you can see here, because of the calcium deposition, it is hyperechoic, so you have less signal because of the posterior acoustic shadowing. As you can see, the more denser it is, the more posterior acoustic shadowing. However, this is just beginning calcification, so you can still see some portions because it has not been complete yet. Most probably there are only patches of calcium, so the ultrasound can still pass through. Then in other problems like autoimmune disease like rheumatoid arthritis, synovitis, or synovial hypertrophy, there is a dilatation of your subacromial subdeltoid bursa and your synovitis. This is actually hyperechoic synovitis, so this is a little late na because early signs of synovitis is also anechoic. That's why if you try to compress it, it is non-compressible. Think of early synovitis. So this is the Euler-Omerat synovitis scoring. You just have to determine the extent of hypertrophy, the extent of vascularity, because the higher the vascularity, more than 50% of the total gray scale already have vascular changes or neovascularization, that is a higher grade. So the combination of the grayscale and the Doppler, kasi usually, as I said earlier, if it is earlier, it is anechoic, but if it is hyperechoic, most probably it is already grade 3. Then if you have more than 50% of neovascularization on Doppler studies, make sure that it's pulsatile and it's not just movement. Because remember, if you keep on moving your probe, any hyperechoic structure will light up. So you have to make sure that your hand is very, very stable. So you get the scoring of the vascularity. Then another criteria for rheumatoid problems, you have to look for biceps effusion, bicipital head, as we have mentioned earlier, the anechoic circle. Then you have glenohumeral effusion between the glenoid and the humerus. This is seen in the posterior aspect. Then you have full thickness tear of the tendon, and then also you either have a partial or a full thickness tear. Take note that the most predictive sign is because of the neovascularization also. Now, whenever you think of other pathologies, if you have multiple masses in the subacromial subdeltoid bursa that lights up in duplex scan, in the duplex, if it is duplex positive, Doppler positive, most probably it is synovitis, and you have to rule out pigmented bilionodular synovitis. It is a rare benign proliferative synovial tissue proliferation. Now, also osteochondromatosis in the synovium, you can see calcium depositions, and you can see it actually intrabursal hyperechoic masses. Also, infection in the subacromial subdeltoid bursa, if you are doing sonopalpation and it moves around, but it is a heterogeneous or a complex signal, most probably, and the patient has symptomatic signs and symptoms, probably you have to think of infection. Now again, the supraspinatus, as we have said, we just jump back. So this is the supraspinatus articular cartilage humeral head. So how do you do it? You have to put the arm behind so that you put the supraspinatus more anteriorly and a little more. If you put your arm posteriorly, you expose more of the tendon because in the anatomical position, the acromion will cover the supraspinatus. So in the arm, in this position, again, the probe indicator pointing to the nose of the patient. So this is your tendon. Always compare the normal and the abnormal. Usually it's 4.9 or 5 millimeters. However, in elderly, because of chronic inflammation, it causes synovitis. And of course, you have to look at the tendon grading. You have to look for fascial discontinuity, neovascularity again, calcification if it is late, and tendon thickness. So as you can see, if there is less than 25, more than 25 to 50, more than 50, or complete tear. So that would tell you if it is high grade or low grade. Neovascularization, again, very important. And tendon thickness as you compare the normal from the abnormal. You can see that because of the chronic irritation, it causes hyperechoic changes. And sometimes, because of the hyperechoic changes, it decreases the signal under. So make sure that it is not anisotropy or because of the decrease of the signal that causes the decrease in the signal under the tendon. Because sometimes you might mistakenly sign this out as a partial tear. Again, tendinosis, increase in size, and you can see that there is increase in the acromial subdeltoid bursa. So this is, as you can see, the tendon structure. And if you do dynamic movement, and if it bunches up, if it impinges on the acromion, increases size and the fluid increases, you have the capsule distending, then you think of a tendinitis. Again, bunching up of the tendon, as you can see, this is normal. You can see that the greater tuberous, it goes totally under the acromion. But here in the acromion, because of that abduction, there is bunching up of the tendon. Whenever we do injection, we always aim for the subacromial subdeltoid bursa because it is said that 90% of tendinosis can be given with tendon as long as you don't inject the tendon. You inject the steroid on the bursa and it will decrease the inflammatory, then it might revert back to normal. Again, this is your injection. As you can see, the needle going into the subacromial subdeltoid bursa. These are some of the things that we can do. If you have partial tears, you can do PRP to try to heal the tendon. So injection again is under ultrasound guidance, and you can do injection. Remember that when you inject the subacromial subdeltoid bursa, you have to aspirate first because the fluid inside is usually acidic and it can cause further destruction. So you have to remove everything before you inject. And when you inject, you can see that as you are injecting, it is distending, then it then pushes normally back because it is trying to disperse to the whole area. Now for supraspinatus tear, you have the dorsal-sided, articular-sided, intersubstance, and full thickness tear. So comparing ultrasound before and now, as you can see before, they are finding out that for partial thickness tears, these are the sensitivity is not so high because they found out arthroscopically that some read it as partial thickness, but it's actually full thickness. But in full thickness tear, you can see that the sensitivity is very high, up to 100%, and the specificity is very high also. So if there's no tear in full thickness tear in ultrasound, most probably there is not. So how do you determine? Determining by the thickness, full thickness, we have all these parameters, the cartilage interface, the cortical irregularity, the tendon being compressible, the sagging fat, and the convexity. So these are the things that you look for. So whenever you look for, you also look at the partial articular supraspinatus tendon tear. So we all look at this. So for dorsal-sided tear, you can see that this is the supraspinatus, this is the tear, so it is less than 50% at the greater tuberosity, and this is actually, there are still some tendon that is attached, but it is almost complete. So this is a tear also, but there is still partially, the tendon is still partially there. Always confirm the long axis with the short axis. You can see the anechoic signals in short axis. In the intrasubstance, you can see that above and below the tear, there is still tendon, as you can see in short axis also. Now for partial tear, there is a grading. If it is less than 3 millimeters, 3 to 6, more than 6. So the reason is it is either surgical or non-surgical. As you can see here, there is either articular-sided, the tear is here at the articular side, or on the dorsal side, as you can see here. Then, if you have full thickness tear, you can see that there is complete disruption of the supraspinatus from the greater tuberosity, and you can actually see part of the cartilage. Remember that the cartilage is ideally anechoic, but because of the great disparity of fluid in the cartilage, you have this hyperechoic rim. So that is the signal that there is nothing on top of the cartilage. So aside from that, not just knowing if it is full thickness, you have to determine where the tear is, because surgically, this would tell us that we need to do something to heal the patient. These are the different classifications: the crescent, the reverse L, the L shape, this is the trapezoidal, and this is your massive tear. And if you apply AI, there are the little studies that I saw in shoulder for AI is for full thickness tear. As you can see, the partial thickness and most probably the full thickness are the one that is a little bit more sensitive. However, there is not much correlation. However, it helps the surgeon determine what to do. Then, aside from that, you have to determine where the supraspinatus tendon is. If it is near the area of rupture, that's grade 1. If it is already showing the cartilage, that is grade 2. If the whole tendon is retracted, that is already grade 3. Why is that important? Because of the chronic retraction of the tendon, it causes fatty change. And when you have fatty change, you have decrease in the function of your muscle. That's why it is 92.5 accurate to use ultrasound to determine fatty degeneration. Normally, the fat is isoechoic. However, when it is near muscle, it becomes hyperechoic, as you can see here. This is isoechoic. But because of the low signal of the muscle, it then renders your fat hyperechoic in the muscle. And you lose the pennate pattern of your muscle. So again, between the spine of the scapula and the clavicle, that is where you put your probe. Then you look for the muscle. This is your supraspinatus, the trapezius muscle. And then what you do is you look for the suprascapular notch. Suprascapular notch, no? You put the probe, the middle of the probe at the middle of the suprascapular notch. Then you turn it 90 degrees to try to get the area. Then you look for the junction between the trapezius and the supraspinatus, that is the fascia. Then this is your area. So you have to get the length of the supraspinatus. Then you get the ellipsoid area. Then you compare if there is fatty change or not. Then depending on the amount of fat, so you get the ellipsoid of the fat and ellipsoid of the muscle. If it is more than fat, most probably, even if you do surgery, it might not help the patient because the muscle is not usable anymore. So again, isoechoic, slightly echoic, markedly increased. So this is our patient. This is the normal muscle. This is the isoechoic signal. So you only have 0.9. So if you do surgery, you can help the patient. Another thing is your myofascial trigger point. This is the fascia. And if you look at elastography, it is not moving because as you are applying the vibration, the muscle usually absorbs the vibration and it moves. However, if there is fibrosis, it does not move. So you know that this is your trigger point. So what you can do, because of the hypoechoic trigger point, you can actually put Doppler and there is increased vascularity because of that scar formation. So what you do is you put your needle and you try to inject and try to break and release the trigger point and it can help. So this is your needle as you try to hydrodissect the muscle away from the fascia. Then, of course, for post-operative, this is the supraspinatus. You can see that actually the sutures here. So whenever you do post-surgery, you have to wait 2 weeks because in the first 2 weeks, you have to look. There is a lot of signs of bleeding, hematoma, so it will disrupt your finding. After 2 weeks, this is the things that you will see. You can see that there is continuity of the tendon. It is in the correct position, in the greater tuberosity, it has adequate thickness, and there is adequate tension of the subacromial subdeltoid space. Because if the tendon is disrupted again, the subacromial subdeltoid space will increase in size again. And again, post-operatively, these are the what you call the findings that we see. Then, of course, calcific tendinitis, if it is very hypercalcified, there is already posterior acoustic shadow. If the calcium is still milky, it is like this. And there is sometimes a rim of calcium also. So what we do is we insert the needle and push saline and retract it to remove it. So the rotator cuff interval, again, you see this. This is, you try to look for the triangular space of the inferior and superior middle facet, so you know that it's the supraspinatus versus the infraspinatus. And as you are moving it, you can see that the bird beak pattern, as it is becoming flatter, you know that it is the infraspinatus. And the infraspinatus, whenever you do it, you have to look at the posterior, to look at the labrum, the glenoid. Then as you are internal and externally rotating, you can see that this is the glenoid labrum, and this is the infraspinatus. So these are the things that you have to look for, the tears, and if you have to put injection, make sure that you look for the junction between the humerus and the glenoid. Sometimes with posterior dislocation, you can also see the V-shaped disruption of the bone, And you can see the coracoacromial ligament. This is another structure. This is the coracoid. This is the acromion. This is the ligament that sometimes can destroy the supraspinatus tendon. As you can see, as you are moving the supraspinatus under, it can cause dropping on the coracoacromial ligament. So this is the coracoacromial ligament. This is the supraspinatus as you are doing internal-external rotation. And usually it is said that the shorter the coracoacromial ligament is, the higher the incidence of supraspinatus there. This is again one of the supraspinatus nerve, no? Suprascapular nerve, which is sometimes impinged, and you can do arthroscopic release. You use the ultrasound to guide your arthroscope, and with seeing it with the arthroscope, you can release the nerve without injuring the blood vessels. So again, this is your adhesive capsulitis. What you look for is your coracoacromial ligament, the axillary recess, the rotator cuff interval, and the biceps tendon. In the axillary pouch, as long as the pouch is there and it is not sagging, it is normal. Because if you see thickness in all these structures, you can know that it has your adhesive capsulitis. So thank you very much for your attention. And I'm sorry for...
Thank you very much for an excellent lecture, Dr.
I'm very sorry.
I'm certain that our rheumatologists and physiatrists are so eager to ask you questions, but we will hold everything in abeyance because Dr. Oscar Parr is already on standby. He actually listened to your lecture, Dr. So we will play your recording first, and yes, we will fix it. Good morning, Dr. Oscar Parr. And then he will join us for the open question and answer.
Hello to everyone. It's my great pleasure and honor to be giving this lecture. Before the title of the real presentation, I just would like to welcome you to this presentation with this recent title of ours, From Magic to Strategic and Logic in MSK Ultrasound, Hocus, Pocus, and Focus. Of course, Hocus stands more for the magic side, but Pocus is the point of care ultrasound, and Focus is, of course, the focusing function of the machine. So, Hocus Pocus and Focus, welcome to this lecture. Today, and before I start, of course, I would like to thank the organizers for their nice organization, for this nice meeting, and also for inviting me once again to this Congress. So today, the topic is artificial intelligence in ultrasound, MSK ultrasonography. But I just tried to start with intelligence and ultrasound because artificial intelligence means nothing without normal human intelligence. So I will try to take you through a discussion on artificial intelligence and MSK ultrasound. And just before I start, I've been doing ultrasonography for the last 23 years. And it's more than science and research for us. It's also passion, and it's also some sort of emotions for us because it really complements what we are doing in our daily clinical practice. So I'm Levent Özçaka. I'm from Hacettepe University from Ankara, Turkey. And here you see my other affiliations from other countries. And just a short reminder for the 3 books and our study groups and our social media accounts if you're interested to join us. Now, the technology is every day it's really developing, and it's increasing and increasing, and the technology in all imaging techniques is also reflected through ultrasound. And this is just a sort of 3D reconstruction of my forearm with the median nerve here. So you can, with nice techniques, you can dissect it, you can reformat it, and you can have some vascular evaluations. You can use some sort of different power Doppler imaging. So the technology is really evolving. It's not just in ultrasound, also in other techniques. You see, you have different machines, you have different instruments. You see the glasses on the right side, where it just opens a sort of virtual screen. So when you're doing sort of interventions, you don't need to look at the screen and the patient. When you look at the patient's knee or shoulder, for instance, the screen, the ultrasound screen, is just over there as virtually. So following this technology, it it's not possible to keep away from the use of artificial intelligence in clinical practice. But before that, perhaps just I would like to open a short parenthesis. It might be perhaps more appropriate to distinguish what is actually being done in radiology and what is actually done in clinical sciences, in this case, musculoskeletal sciences. It's a little different. We prefer to use the terminology of ultrasound examination because we really believe that is just, after listening to the complaints of the patient, physically examining the patient, ultrasound is sort of ultrasound examination, just the continuum of physical examination. And we usually believe that it's not just showing the images and showing the pathology. Ultrasound can only be the sous chef, and the clinician is always the master chef. So at the end, whether you use artificial intelligence or you just do routine ultrasonography, you are the person that will relate the night pain of the patient or the persistent painful complaints of the patient with the ultrasound screen, let's say sort of inflammatory findings on the screen. So with or without artificial intelligence, MSK ultrasound can only be the sous chef, and we never should forget master chef is always the clinician. So my presentation will comprise some literature review, some papers, because it's really hot topic, especially in the very recent years. And I will, at the end, give also examples what we are doing in our daily practice using artificial intelligence. So I just went through PubMed, just put these keywords, and I wrote ultrasound and artificial intelligence. You can see that's like 25,000 papers. And if you specify it more, like MSK ultrasound and artificial intelligence, it is something like 200 to 300 papers. And when you look at the yearly distribution, you see that it went ballistic in the recent years in both sides. But you can see that the use of artificial intelligence in other types of ultrasonographic examinations is also older than the one it's used in MSK ultrasonography. So, but it's skyrocketing, especially in the last 2 to 3 years, even I don't say the last decade, in the last 2 to 3 years, it really skyrocketed, and we need to care for this. We need to try to understand for this. And again, I would like to thank the organizers once again to let me discuss this topic in this meeting. So what we are talking about, I will try to define it first because it has also some engineering sciences side of the story. So I will not go into detail in that side much, but I will more take you through the clinical use. But what artificial intelligence, we need to understand it first as clinicians, as physicians. So it is something like a sort of mathematical modeling, which can be trained and which is in algorithmic ways is designed to look like human neurons, their working patterns. Some definitions, I found this one is quite descriptive. So it's a sort of intuitive process that refers to the capacity of machines to perceive information, retain it as knowledge, and apply it toward adaptive behaviors. So you provide data, and with some procedures I will try to explain, it also learns the things, and sometimes it can really become quite straightforward, quite rapid, and quite correct as well. So it can handle extremely large numbers of variables, sometimes outperform standard statistical analyses. So it also comprises some analytic parts, statistical analyses. But don't forget, does not solve the fundamental problem of the causality. So you find something, but you are at the end the person, the clinician, the radiologist, or the physician who will eventually relate that finding to the clinical scenario of the patient. So in clinical practice, if you look, especially in the radiological side, it has been used for anatomical identification. It has been used for pathological diagnosis. It has been used for clinical data analysis, image analysis, some recognitions, radiological assessment, indisputably, and text reading. It has been also to understand certain words or to capture certain words from certain reports. Now, as I mentioned, I will try to exemplify some nice papers, review papers or studies in this topic, and I will try to make it as simple as possible, and I will try to make it as comprehensive as possible in terms of the clinical side. So this is a good schematic explanation for the history of the use of artificial intelligence in radiology or in clinical practice. So it is not that recent when it first started. But if you look at these years, like after 1991 or 1992, especially when the use of neural networks or convolutional neural networks has been established, it has been really much more used in practice. So as you have seen in the PubMed reviews in the last 2 to 3 years especially, it went ballistic. Some examples of how it can technically detect things, how it can diagnose or classify things like benign versus malignant, or with some sort of segmentations, how it can precisely locate the boundaries. So how do I get started? This is the main question clinicians are terrified with. Okay, you're talking about, I think, good things, but where should I start? So how do I start understanding it, learning it? This is a nice paper published last year in Skeletal Radiology. So I took some definitions and tried to, including myself, try to explain it to dummies in artificial intelligence. So what does it mean? It's a sort of ability of an algorithm or set of computer instructions that can mimic human behavior. Machine learning is one part of it, is a subset, where the algorithm learns this ability somewhat automatically using the data, okay? And deep learning is another subset of it. So artificial intelligence, machine learning, and deep learning, which is defined by using an algorithm structured in multiple sequential layers and designed to mimic the functioning of a neural network. I will give some examples to make it more clear. So deep learning can also be discussed in itself. It requires larger amounts of data than other techniques. So you really put several data, and it has training data, it has validation data, it has testing data. So you have to train the model, you have to validate your model, and you have to test at the end whether it can really do things in a correct way. So they made some similarities very nicely. So the training data is like primary course lecture materials or books. Validation data is corresponding to practice tests, and the testing data is the final exam, okay? So you can see some steps, how the convolutional neural networks can match the things and at the end have prompt figures of prompt photographs. In the meantime, we have to be careful for certain things. What deep learning cannot do at the moment, okay, it is a trained algorithm, but usually on one or a very limited number of diagnoses at one time. So it cannot diagnose each and everything at once. It does not have emotions, it does not have intuition, so you need clinical interpretation, how you can integrate and understand the biomechanics of an injury and relate the other parts of the injury. For instance, when you see a radiological injury, okay, you know as a clinician or a radiologist, you know that it is related with some part of the pathology, or when you see this pathology, there should be also another pathology in the next, just the nearby joint or the nearby bone. So you have to interpret the other things, and you have to also look for other things as a examiner, but it does not do it if it's not trained that way. So it has a complicated neuronal network, and it's not possible to strip down each neuron and ask it why it arrived at that conclusion, okay? So this is the sort of black box issue. Sometimes it could be dangerous, but it could be also less trustworthy. So the black boxes within these algorithms still need further research. So on the formal side, for instance, how does FDA approve these methods or techniques or things, products in the market? The simplest way is it requires institutional review board approval or experimentation at a hospital. Of course, if you're not talking about a single center use, but more than a single center, multicentric use, it has to go under these stepwise approvals. And I know, for instance, the ECHO model that has been published in the JAMA was accepted by the FDA as a de novo pathway. So it does not have any legal counterparts in the market, so it is separately evaluated by the FDA. And depending on the level of approval, you can use artificial intelligence as an add-on technique or a standalone. Of course, if you're going to use it as standalone, you have to have a higher level of approval. But add-on, okay, you can use it before, during, and after the human interpretation. Another nice paper, artificial intelligence being explained for non-experts. So there are also things, okay, this is a nice diagram showing the subsets. So the machine learning, deep learning, neuronal networks, and the convolutional neuronal networks. But in total, it's the artificial intelligence. What is named by input, okay, what the model is given as a single image or a sequence of images. The output, what we are trying to predict, like the diagnosis, eventual diagnosis, and the machine learning is the methodology. So it can have different types of learnings: unsupervised learning, supervised learning, or reinforcement learning. But this is the most common one, the supervised learning, and it's also showing the most practical success. It has classification, it has segmentation, and in this supervised learning, I will show in a minute the networks, the convolutional neural networks. If it's not based on those techniques, it is usually based on logistic regression, decision trees, and support vector machines, and so forth. So it really has complicated analytic statistical analyses as well. So what are neuronal networks? These are learning models, different layers. I don't go into details. Computed as functions, the outer one, the inner one, the hidden layer. But these are sort of different complicated functional algorithms. And the neural networks is the sort of architecture defined by a number of different layers and how they are connected. And this is also the subfield of machine learning. The convolutional neural networks has been shown to yield the greatest success. And some names, just a name, is these type of models. I will give in the coming papers. There are different models that are being used in the literature. So this is an example of a neuronal network, and this one is a convolutional network. Okay, and this paper also highlights the challenges and limitations. Of course, we know that the medical images are very different from natural images. So there is the issue of difficulty in interpretation. So testing and validation are very much important, calibration, and we need to be cautious against some hidden variables in those black boxes, robustness, and the safety of the data. Okay, another review just to show how machine learning and deep learning work in schematic drawings. Different statistical analysis that it can use, like logistic regression, nearest neighbors, neural networks, k-means, random forest, and so on. I don't go into details, but if you would like to read further, these are the nice or the best reviews that I could find from the literature to understand and to explain in a simple but also in a comprehensive way. Again, different models, so how artificial intelligence uses these images, different segments, at different steps. This is an example of muscle imaging, for instance. So deep convolutional neural network on based fiber orientation. So these are images from different gastrosolius complexes where the deep learning process takes place and can understand and can detect these types of pannation structures of the muscles. Examples of how it can detect synovitis, accumulation of fluid, or synovitis, you see. Lumbar spine, image identification for lumbar spine is a good example of the process. For nerves, I will give some examples from the median nerve, but the nerves are also being studied, how to detect and how to measure them simultaneously. For the median nerve, cartilage, if you would like to assess the cartilage at different zones and at different steps. So this one, UNET, the model that has been used for this analysis. So again, they also put a note saying that, okay, it overcomes high variability, operator dependency, okay, but two-dimensional and three-dimensional imaging, when you're doing some strategies to reconstruct and so on, okay, we should be cautious. They are promising, but we should be cautious. They are not the same thing. We should be cautious about the artifacts. We're talking about, user dependency and different sort of technical artifacts and sometimes difficult artifacts that we cannot overcome. So when you're providing the image to the system, you need to be cautious about the artifacts, and there need to be careful curation and quality assessment for the input for the training data. And of course, image variability among centers, among machines, among probes is also another challenge that we need to think of. Okay, can artificial intelligence increase my day-to-day efficiency? Yes, it does. How? And this is a good diagram summarizing, starting from the scheduling and protocoling step, image acquisition, detection and quantification, diagnosis, reporting, treatment planning, treatment, and follow-up. At all these steps, especially this is a model which can exemplify the radiology imaging chain workflow as indicated here. It can help you. To what extent? Again, don't forget, Master Chef is the physician. He has to decide whether he could use it before, during, after, as a supplement, as an add-on, as a standalone. So we need to care for it. A common question, does artificial intelligence outperform natural intelligence? This is the conclusion. I just put it. This is a nice paper from the orthopedic category. They have comparable performance to clinicians. They are comparable, but they enhance the performance as a technical supplement rather than a replacement of clinical intelligence. So this is sort of another explanation of the same issue that I tried to mention. It cannot replace at the moment, but it does really help during the daily practice. This is another interesting paper. When there are increasing number of papers and evidence of data, people started to think, okay, can it pass the fellowship examination, a particular fellowship examination? And they did this study. And in the introduction, they nicely quoted the statement of this person in 2016. He said, we should stop training radiologists. Now it's just completely obvious that within 5 years, deep learning is going to do better than radiologists. So the authors of the study said that, okay, it's already more than 5 years. Let's check it. Is the statement correct? Has it found position in life or not? So I just put the conclusion. Further training and revision are strongly recommended, particularly for cases the artificial intelligence considers non-interpretable. So there are vague images. Sometimes, it cannot understand, and especially for those borderline images or pathologies, further training is definitely necessary. Not yet. The short answer is not yet. Okay, some examples from studies, not reviews, but studies. This is for transverse hemispheric ultrasound images for neuromuscular disease assessment. So you can see different images like of the tibialis anterior, the gastrocnemius, the biceps. and with normal echogenicity and with abnormal sleep pathological compartments, and how it evaluates the deep learning works on these models, on these data, and how it can detect. And you can see here it really example of an image with equal performance on A. In B, this is a worse performance, and in C, it's actually a better performance. So they say that, okay, it can accurately segment the cross-sectional area of muscles, but again, they say that our future work will include developing models, not just to segment, but also provide an automatic classification of neuromuscular disease types. Another example of working on the skeletal muscle fibers again, you see different schemes, and again, they say that this is the first generalized prediction of muscle-specific EMG, joint angle, joint moment, and standard frame rate, B-mode ultrasound images. And they say that it has potential applications for clinical assessment, monitoring the treatment, and biofeedback for different steps. Another example of working on muscle fascicle length using artificial intelligence, I will not go into details. Rheumatic diseases, also not just in neuromuscular side, but also on rheumatic side, it has found some path, and I will just give examples of images that have been used to morphologically classify with associated meaning, texture recognition, edge region detection, and this is the raw data. So they say that it helps to identify and analyze what might not be apparent to the untrained human eye. This is very important. What a normal person as a human eye cannot detect. With tremendous amount of data, with deep learning, these algorithms start detecting what we cannot detect with normal eye. So it really does robust quantitative measurements and abstract interpretations on pixels, edge, texture, region, and object detection. It can be also used for localizing muscles and compartments, also for injections. So it's an example of the how machine learning can delineate the adductor canal for injections of the obturator nerve. I mentioned, as usual, carpal tunnel syndrome, and the median nerve imaging is a commonly studied model. So I give an example of one of these studies in the literature. They have done a study on carpal tunnel syndrome patients, and they found really excellent agreement between the detection of the artificial intelligence and of the expert rheumatologists. Another study of carpal tunnel syndrome again, and these authors say that, okay, artificial intelligence can increase the radiologist's understanding of B-mode images, and also can be employed to diagnose carpal tunnel syndrome. Now, in the last part of my lecture, I will give examples of what we are doing in our daily practice, both for MSK ultrasound side, imaging side, examination side, intervention side, and also a little example, just a single example on how we use it in PMR side, the physical medicine and rehabilitation side. So this is a recent review and meta-analysis we published in this year of the studies on the median nerve. So when you look at the abstract, the summary, we have analyzed the 7 articles on median nerve artificial intelligence ultrasonography papers, which comprised 373 participants. You can see they have used different models of deep learning, and a conclusion is just straightforward, and we say that it enables automated localization and segmentation of the nerve at the carpal tunnel with acceptable accuracy and precision. So this is the robust statement that we can use in median nerve, MSK ultrasonography, and artificial intelligence. Acceptable accuracy and precision. Another thing that we have published is regarding how it can detect, or whether it can detect, the calcific tendinopathy on ultrasound, on shoulder ultrasound. So you see the how many images have been evaluated. So this is this DenseNet was the algorithm that was used in the study, and the result was the longitrans model worked the best. So the longitudinal transfer model developed with this algorithm was better for the diagnosis with the accuracy, sensitivity, and specificity of these numbers of a really high level. And what we are trying to also include in the market as an app is we have the USPRM, Euromusculus protocols for basic protocols for the shoulder evaluations, shoulder examinations. We have learned and we have trained the model, our model, with the Euromusculus USPRM protocols. So what we have currently at the moment, so this is an example from the elbow. Artificial intelligence added ultrasonographic protocol when you're doing live imaging, so it can detect these landmarks that we have trained. So this is the radial head, the humerus side, as step one. And then when you find all these landmarks, it tells you go to step two and scan the fossa, where you need to start evaluating the elbow joint to check for joint fluid. So we have 42 windows of 6 joints: shoulder, elbow, hand and wrist, hip, knee, and ankle and foot. All these joints, as a total of 42 windows, artificial intelligence can guide you, can navigate you, especially for beginners or especially for, let's say, non-experts who would like to do for training or for daily practice, who would like to work with ultrasonography of these joints. So we have this not yet in the market, but we are working on its clinical trial for the validation. And this is just an example how you can add simple measurements. Of course, again, if you need to. This is an example of supraspinatus when you're doing live imaging for the supra in the cross position. The pink is the deltoid, the green is the supra. So at any time, at any site, at any number, you can have the thickness measurements. We have these types of measurements for, in this case, the supra, in the ankle, for the Achilles, the plantar fascia, for the median nerve. So again, what you think is relevant, you can add to the algorithm, and you can simply do all these quantifications. This is the example of our model for the intervention site. That's the nerve blocks. It's already in the market. So if you put the, you see on this photograph or this video, you see how the probe is moving, and as the probe is moving, you see the different muscles and your target for the cervical plexus block. This is an example of the nerve blocks technology. So in the previous meeting, I have given the example from the sarcopenia guide of ours, which is based on ultrasound measurements of the rectus femoris of the quadriceps. But with SarcoX study, now we are trying to refine this model using, this was the algorithm. So at one step, you have to do ultrasound of the thigh, and you have to have star measurements. But with more than 5,000 patients and with increasing number of data, now we are trying to refine the model, and we are trying to understand with complicated artificial intelligence analysis for which patients perhaps we can say that, okay, in this case, we don't need to go with the grip strength, or we don't need to go with the ultrasound, and with simple measurements, easier and more convenient, we can end up with the diagnosis of sarcopenia. So these are the models that we are working. And this is the last thing that I'm going to show. This is how we try to use artificial intelligence to assess the chair stand test performance of subjects with clothing, without clothing, and with markers, without markers. So this is a great ease, especially for elderly, without using any markers, living in a nursing home, just using this app and try to understand the performance of the chair stand test without having the patient come to the hospital and using, getting naked and then putting the markers and so on. So this is the chair stand test model. You can see all the numbers, all the quantifications and also the comparative analysis of these graphs. So not just for imaging, but artificial intelligence can be used with different concepts and different complicated analysis in clinical practice. Okay, again, I hope it's not 30 minutes yet, but I hope to finish with the books with different translated into different languages if you would like to have a look into. And I would like to thank once again for your attention and hope to meet you with the Q&A session. Thank you.
So thank you, Professor Özkakar, for that very, very beautiful lecture and very, very enlightening. This will be a working lunch. So, Professor, we will send you your food. We will send you the food to you. Sorry, but
thank you. We love Filipino food.
Yes, I know. So we're going to ask you to visit us one of these things a year so that you can really, really teach us your this new technology, which is very good. So at this point, are there any questions from the floor?
Any questions? You almost gave our, you know, the room is filled maybe 70% radiologists, and one of your the studies that you presented was do we need radiologists in the future? You almost gave them a heart attack.
No, it was fortunately not my study. I do disagree with the paper, and I was just curious to see that question. And that really is sometimes I have discussions, nice chattings with my radiologist colleagues, and they are sometimes also anxious for this. Is our specialty disappearing in the future? I definitely disagree. But that was what they quoted in the introduction. So one of the guys, of course, the question is coming not from the radiologist, coming from the engineering sciences side. And they, as opposed to his comments, say that, okay, you were saying this, it's more than 5 years, let's see. And the answer is, of course, never. I'm a little old-minded person. I do disagree with the question. And I also disagree with the clinical side. I mean, some people even say that, okay, in the future we don't need doctors. Artificial intelligence can just diagnose everything. Perhaps we need physios and we need technical staff that directly give service to the patients. And I fully disagree with this question either.
That's good. That's good. Thank you.
I actually agree with you that artificial intelligence is an adjunct because it is still the mind of the doctor that can see everything. Because in artificial intelligence, they are only focused on one area, while the mind is looking at the entire pathologic problem. So that is very good point that we do not agree that it will replace us. So everybody from the room, let's be happy. Any other questions?
I have a question.
Yes, Dr.
Okay,
Aicardo.
Dr. Özkakar, with your practice and with AI, how much help did you get from AI with regards to your workflow efficiency or scanning time, or
I mean, we have not yet incorporated it in our daily practice. What I have shown is all on research side. So we are in a tertiary care center, and as a full-time professor, I'm doing perhaps more research than my clinical practice side. And what I have shown are just, I mentioned that we are doing the validation study at the moment, because unless you validate your results, there are black boxes, there are many questions before you apply them in your clinical practice. So at the moment, I have perhaps 0% that I use all these things that I have shown in my clinical practice, but these are things that we are now producing. One side, the nerve blocks, is already in the market, but the artificial intelligence related with the basic joint scanning protocols is not yet in the market. So and those measurements also, just the engineers sent me that video just 10 days ago. It's really the smoke is coming out of it. I mean, not in daily practice yet.
amazing that engineering and the medical field are now marrying each other to get into these things, right?
Yeah, not yet children. We don't have children yet.
No children yet.
Not yet.
Not yet. So actually, I came across a paper that said that AI actually helps orthopedic surgeons change their decision in surgery because, like in the rotator cuff tear, after using the AI in the supraspinatus scan, they found out other pathologies that was missed during a standard ultrasound. So, what is your thoughts about an adjunct to help us decide on what to do in the future regarding like surgery or your management for sarcopenia and all?
Well, again, I do believe that it might tell us, okay, perhaps you've skipped this. I found this in my examination. So it might only tell the physician or the surgeon or the radiologist, just perhaps reconsider your decision. So I believe that, okay, you might have something on the ultrasound scan, but unless, as the orthopedic surgeon has nicely lectured, unless you press it, unless you sonopalpate it, unless you really find it relevant or related with the complaint of the patient, the night pain of the patient, the disability of the patient, unless you relate it with the functionality, finding just a 2 millimeter anechoic space somewhere in the space, to me, does not mean anything. So it should be clinically relevant. And that's also the reason why we say it is the continuation of the physical examination. And it's not just seeing something on the image and trying to make comments regarding it. It's also the same for electromyography, for instance. When you're diagnosing simply carpal tunnel syndrome, if you find something in the EMG, but it does not, if the patient does not have clinical findings, are you going to operate or are you going to inject? At this moment, I think this is just unnecessary. And it can only provide sort of double check as regards your medical or surgical decision-making process.
That's right. It's really very promising. So at this point in time, again, thank you very much for gracing our convention, Dr. Levan. And
My
thank
pleasure
you
and
for
honor.
waking up really early to be with us in this live.
No, this time I'm in another Congress and my session is starting in 20 minutes. So I will be
Okay.
going to my
All right.
session
So
live.
we'll let you be in that conference. Thank you very
Thank
much.
you.
An
We hope we
honor.
can invite you again.
My pleasure and
Hoping to
honor.
see
Thank
you
you.
here.
Thank you.
Yes,
Mabuhay.
thank you
Mabuhay.
so much.
Mabuhay.
Mabuhay.
Certificate of Appreciation is awarded to Dr. Robert Chan for his grateful recognition of his invaluable service as speaker on this 21st Annual Convention and 25th Anniversary Celebration, meeting today's challenges with innovative and intelligent ultrasound, signed by Dr. Patria Cecilia Martinez, Dr. Vincent Panhong.